Greetings. My name is Brad Monk, and we are live. I'm so happy to be here with you. We are live with our panelists, and someday, very soon, we will be live with you together. In fact, I just invited you to the Energy GOG meeting the second week of February and to Phoenix again the third week of March so we can be live together. I'm not able to announce that the pandemic is over, but it's over. So,
all right, brother.
Welcome to my co-moderator, Rob Coleman.
It's good to see you. Thank you so much.
Thank you. This is the GOG highlight reel. This will be the first in a series to review key abstracts and data presented efficiently and comprehensively to you. And before we get started, I'd like to turn it over to our president, Professor Larry Copeland.
Thank you, Brad. Rob, it's great to be here with everybody. We look forward to eventually having a live audience, as Brad has already referenced, for this new highlight reel program developed by GOG partners. Hopefully, we'll be able to do that soon, as referenced by Brad, maybe this spring. Even though we've been apart for 2 years, I can tell you this group has been very close by virtual meetings on a daily basis. The GOG continues to grow. Most noticeable has been the expanding GOG Partners portfolio program. And we are working with our pharmaceutical partners to develop new clinical trials, bring new agents to benefit our patients. It's been an incredible year seeing new agents from our GOG clinical trials receive FDA approval, bringing new options to our patients. Today's educational event is an example of the incredible work that has been done through the GOG. It is important that every one of you participate and support our mission to transform the standard of care. Thank you, Brad, Rob, Katie, Brian, Dave, Leslie, Ramez, Bhavna, Angeles, and Tom. You have done a marvelous job running this program. For those of you who have not had the opportunity to open and enroll to clinical trials, our clinical trials, we look forward to your participation. The GOG is here to welcome you with open arms. Enjoy the first GOG Highlights Reel program. I'm going to pass it back to Brad to kick off the program.
Cope, thank you, and thank you for your mentorship, your vision, your leadership. It's been transformational. So I invite you to join us in the chat function. We're going to have an engaging and fun opportunity to hear today. What I'd like to do is go over our objectives. Our objectives are threefold. To increase knowledge regarding the three main buckets of our cancer: cervix, ovarian, and endometrial cancer. We're going to talk about current agents and regimens through highlighting key data that was presented at these fall meetings. We want you to increase your competence, but also your confidence. Next slide. So in accordance with the ACCME accreditation criteria, the GOG Foundation, as the accredited provider of this activity, must ensure that everyone is compliant and that any relationships with ineligible companies, which we used to call commercial interests, have been adjudicated. All committee planning faculty members were required to disclose all financial relationships, and speakers are required to disclose any financial relationships as it pertains to what we're talking about today. We'd like you to complete the educational survey. And if you do that and attend, you will be eligible for 2.5 hours of AMA PRA credits. There are no fees to this, and we're so honored to bring this to you, and we're so excited to roll. So Rob, thank you. Take it away.
Well, but first, let's thank our commercial sponsors. We are so grateful that they could help us reach all of you And this is a tremendous opportunity for us. And we are so happy that you're here to join with us. So let's get started. You ready?
Ready?
All right.
Do it.
So I am honored to welcome our esteemed course faculty, both Brad and Larry mentioned. It's incredible to be back together in the same room. Actually can physically see you guys, which is great. So I'd like to welcome, as Dr. Copeland mentioned at the beginning, these esteemed faculty. We have Dr. Brian Slomovitz from Mount Sinai Medical Center in Miami Beach. We have Dr. Leslie Randall from the Massey Cancer Center in Virginia Commonwealth University in Richmond. We got Dr. Dave O'Malley from the Ohio State University in Columbus. Dr. Kathleen Moore, who's joined us from the Stevenson Cancer Center in Oklahoma City, Oklahoma. Dr. Amaz Iskander from UC San Diego, my birth city. Thank you. Dr. Angeles Alvarez-Secord, who's joining us from Duke University, Durham, North Carolina. Dr. Bhavna Pothuri, the NYU Langone in New York City, right here where we are. And Dr. Tom Herzog from the University of Cincinnati in Cincinnati, Ohio. Welcome to you all. Thank you for what you're doing for us today. So I'd like to, so let me just say first, I'm going to keep everybody on schedule. Brad and I will tackle you from the podium. There is no doubt we'll take care of you. Just make sure you're on time so that we don't have to hurt you. But we'll try to keep, because we really do want to provide an opportunity for interaction. Dr. Monk and I will be monitoring questions and with respect to these presentations on the chat function. So please use that. We're really excited to be able to address that, and we'll try to get interaction from our entire group here. So with this afternoon's session, I'll start it off with Dr. Brian Slomovitz, who's going to do an update on uterine highlights from the fall gynecologic oncology meetings. Dr. Slomovitz, take it away.
Thank you very much. It's really great to be here. As I'll echo Brad's statement, we're really looking forward to being in person. But short of that, we're thrilled that we've been really working together as a cohesive group, and we're looking forward to sharing this educational event with you. And hopefully we'll all learn from it and see where we're going. I have the great pleasure to be the uterine cancer trial lead for the GOG Partners Group. And in that capacity, it's my job really to have a good portfolio of trials. And what I want to do today is briefly go through where we were, talk about how the recent meetings help change or support the change in standard of care. And then again, briefly just introduce what our next steps are. I think for endometrial, it's a changing field, and it's really an exciting area to focus on. As I mentioned, these guidelines, hot off the press, the 2022 NCCN guidelines, these were released on November 4th. A lot of this isn't really new. It's a lot of the things we knew, platinum, paclitaxel for upfront therapy, and the list of chemos in the second line. A couple things to highlight. One here is, and I'll be sharing some data on the subgroup analysis of this study, lenvatinib pembrolizumab, second line therapy for endometrial cancer. This study changed the world. Vicky Macker and her group really led an exciting trial that introduced non-chemotherapy that's active in the second line treatment of patients with endometrial cancer. And while I'll go through her original data briefly, there's two subgroups that I want to briefly present. In addition, whenever we're talking about how we change patient care, we talk about FDA approvals and compendium listings. Here we have both pembrolizumab, that is a FDA approved drug for TMB high and MSI high endometrial cancers, and also dostarlimab recently got its FDA approval for the same DMMR MSI high tumors. And I'll also be presenting some ancillary data from those studies as well. And finally, here's the recently again released NCCN guidelines for the hormonal queue. This is an area of great interest. Not a lot of updates in this area now, but I think in the near future we're going to have a lot of exciting area as we further develop the second line into first line. The second line treatment for endometrial cancer will represent an unmet need that needs to be filled. Very quickly, this is actually not from one of the fall meetings. This is Vicky presented this at the SGO meeting. Lenvatinib and pembrolizumab for the treatment versus physician choice for recurrent endometrial cancer. A lot of us know this study pretty well. I just want to go through it quickly and then talk about the two sub-analyses that were done. Here's the key inclusion criteria: measurable disease. They required 1 prior platinum-based therapy. It was a 1-to-1 randomization of lenvatinib and pembrolizumab versus standard chemotherapy, either doxorubicin or weekly paclitaxel. The primary endpoint here was both PFS by BICR and overall survival. And this was a positive study. Again, when I said it changed the world, it really did. We could see here on the PFS survival curves, both in the proficient MMR patient population, the difference of 6.6 months versus 3.8 months, favoring the study arm, and in all comers, 7.2 months versus 3.8 months, also favoring the study arm. Similarly, there was a benefit in overall survival. Again, confirmatory trial changing the standard of care in making immunotherapy really in the second line for patients, particularly in this study with with cold tumors, MSS or the pMMR patient population. One of the things that we're concerned about, which I wanted to briefly highlight, is the patients with leading to dose reductions, 66% in lenvatinib pembro. As we get better and more familiar with dosing it, we'll get better at having less and less dose reductions or appropriate dose reductions. And we'll get less actually on the dose interruptions and discontinuations. So in the fall meetings, there are really two studies that were sub-analysis or ancillary studies of this. The first one that was presented by Nicoletta Colombo looked at the outcomes by histology and prior therapy with this combination versus a treatment physician of choice in the Keynote 775 trial. This is really interesting data. We're always worried about maybe the immunotherapies work in the endometrioids, not so much in some of the high-risk histology. This study really demonstrated that regardless of histologic subtype, there was still a benefit to the pembrolizumab therapy. Going from left to right in the endometrioid cohort, hazard ratio of 0.59. This is for PFS. In the serous patients, one of the groups we were worried about, there's activity of pembrolizumab in this group, hazard ratio of 0.54. And similarly in the clear cell, albeit a smaller number, there was still a benefit of pembrolizumab over chemotherapy across these histologic subtypes. This is, by the way, in the proficient MMR population. And we saw the same thing in all comers. When we combined the proficient and deficient, we saw similar benefits of pembrolizumab over all histologies. I don't have the overall survival curves here, but they similarly reflect a benefit of the lenvatinib pembrolizumab across histologic subtypes as well. Finally, what this study did is it looked at PFS by prior therapy and by platinum-free interval in pMMR and all comers. And we could see here that it was statistically significant. For the pMMR greater than 1 prior line of therapy, it did cross 1, and with a PFI greater than 12 across 1, but other than that, it all favored the experimental arm. Summary of this study, lenvatinib pembro provided a PFS and OS benefit compared with traditional therapy in these patients with pMMR status or all comers, regardless of histology, prior neoadjuvant therapy, or platinum-free interval. Patients with 1 prior line of platinum therapy had a more favorable hazard ratios for OS and PFS than those with greater than 1 prior line of therapy. And because this was a post hoc analysis, these results should be interpreted obviously with caution. Finally, a second sub-analysis was presented by Vicky Macker at the IGCS meeting, looking at the subgroup analysis of patients with DNA mismatch repair deficient tumors. Again, the primary study looked at pMMR and all comers. Here we looked at the dMMR population, and really it goes without much explanation, but we see obviously there's a benefit here of incorporating the pembrolizumab and lenvatinib in this dMMR population, both in progression-free survival and overall survival when compared to the chemotherapy. The big question that this study doesn't address, however, is whether or not we really need the lenvatinib in these patients, as we know that pembrolizumab and other IOs are active in this agent. So the conclusions here, 14% treated with lenvatinib pembro had a complete response. As mentioned, the PFS, OS, and response rates were improved with the IO combination. And the lenvatinib pembro had manageable safety profile also in the dMMR population as well. So here I talked about the past, the present, and what about the future? What's next for lenvatinib pembrolizumab? Well, there was there's a trial, LEAP 001. Actually, it's closed in most of the world. It still has a Chinese expansion that's ongoing, looking at lenvatinib pembro in the first line. Carboplatin paclitaxel, our current standard of care, versus lenvatinib pembro. Dual primary endpoints, PFS and OS. And just like the second line study, 775, changed the world in the second line setting, if this study is positive, it would likely introduce an IO-containing regimen without chemo in the first-line setting. We're very excited for these results, and they're hopefully anticipated to come out shortly in the future. Two other trials which I wanted to highlight, which are similar. This was a follow-up data of the Garnet trial. This was dostarlimab in patients with endometrial cancer, looking at the tumor mutational burden status and seeing its activity in related to DMMR or PMMR patients regarding the TMB status. In this study, it was a follow-up study. They demonstrated that in the TMB high tumors, high tumor mutational burden, and if they were DMMR, there was substantial overlap in this patient population with endometrial cancer. These two groups, the TMB high and the DMMR, had similar response rates. The objective response with mismatch repair proficient and TMB high was comparable to that of DMMR, basically saying there's a subgroup of PMMR patients, those with a high tumor mutational burden, which would also respond favorably to single agent checkpoint. TMB high status in patients with PMMR was not due to the MSI high. And again, similar to other sub-analyses, ancillary studies, the study was not powered to really assess this, but it is interesting secondary data. And finally here with single agent checkpoints pembrolizumab, this is a follow-up of Keynote 158. My esteemed colleague Dave O'Malley led this trial, showing that the pembro over a longer period of time still demonstrated a robust and clinically meaningful anti-tumor activity with previously treated DMMR advanced endometrial cancer, overall response rate of 48%, and supporting really the primary study results that were seen in the earlier study. So what's next in this group of patients? This is actually a brand new study that's coming down. We do have permission from the sponsor to talk about this study briefly. GOG 3064, EN15, we're doing it with our colleagues in NGOT, Merck KNC93. Just like single agent checkpoint works in the DMMR patient in the second line, we're pulling this into the front line. We're doing a frontline study, measurable disease, pembrolizumab monotherapy versus standard chemotherapy. Now imagine that we could give patients in the first line, biomarker-driven DMMR, pembro-lerm, well-tolerated, and this study is going to look at that. Interestingly, in the chemo arm, if those patients fail, there'll be a crossover allowed to pembrolizumab, dual primary endpoints, a PFS by BICR, and overall survival. We're really excited to get this trial started, and we're hoping to have first patient on by the end of this year or the beginning of next year. One other trial I wanted to briefly talk about that was presented of interest, the TOTEM trial. The aim of this trial was to compare with a randomized trial an intensive versus minimalist 5-year follow-up regimen in endometrial cancer. Oftentimes as clinicians, we're really not sure how we should follow these patients, how closely we need to. And this study really, in a randomized fashion, looked to see if we could do it in a more minimalistic fashion. The conclusions as presented at the ASCO meeting: intensive follow-up in endometrial cancer treated patients does not improve survival. The quality of life is not influenced by different regimens of follow-up. And according to this data, there's no need to routinely do vaginal cytology, laboratory, or imaging investigations in these patients with endometrial cancer, even in those with intermediate risk. You know, really a practice confirming trial that if we do have a minimalist approach, it is safe and does no harm to our patients. Briefly talking about the future of this disease of endometrial cancer and what directions we're going in. It's really exciting. Unlike any other really time, I think we're really have a good amount of trials. Again, this is my job in the GOG Partners to make sure that we have a good portfolio. We currently have 2 trials of immunotherapy in the adjuvant setting, one through GOG Partners, one through the NRG mechanism. There are 5 first-line trials for metastatic or recurrent disease in endometrial cancer. Unprecedented compared to in the history of this disease to have 5 trials. 3 of these trials, chemo versus chemo and IO. 2 of them are adding a PARP as well. The LEAP trial I discussed. I introduced the 3064 C93 trial in DMMR patients, again, single agent IO. And finally, there's a selinexor maintenance trial, which is a nuclear transport inhibitor being looked at in the maintenance setting. Second line trials, multiple IO and biomarker trials ongoing, and we're really excited to really advance the science in the second line as well. Briefly at the end, what's the current standard of care? Adjuvant, in the adjuvant setting, chemotherapy plus minus radiation. Current standard of care, first line chemotherapy. In the HER2 positive uterine serous patients, trastuzumab as well. Second line, we went through this in the DMMR single agent IO and the PMMR pembrolizumab. Third line and beyond, we still need to figure it out. And the results of these trials are really going to determine if any of these IO trials in the first line are positive. The second line again represents a complete unmet need, as does the third line if we move IO earlier on. I'm very excited about the future. I hope you are too. As mentioned, we'd love for you to participate in our trials, and we look forward to the next highlight reel to hopefully discuss some other some more results of these ongoing trials. Rob, Brad, thank you for your time, and I look forward to our discussion.
Excellent.
Excellent. Thank you so much, Brian. A lot to cover there, but it's really exciting to see how this field has changed so much. So we're going to have a little panel discussion. We got a lot of opportunity from expertise in this room, and I thought maybe we could talk with a question. You mentioned about the lenvatinib pembrolizumab study and its role and how it's moved up at earlier in lines there. But I wonder if you could maybe comment a little about dosing. I think we hear a lot about that from all of our colleagues, and we get consults, and it's come up many times in these things. But I'm curious we have a lot of expertise in this room, so I'm curious as to what your thoughts are about that. Right, you want to start?
Yeah, sure. No, thanks for that question. I really didn't expand upon it. The starting dose of lenvatinib in the trial that was done is 20 milligrams with appropriate and liberal allowance of dose reductions. That's the bottom line. There are some when in the real world, asking trenches or whatever you want to say, there are people who start at lower doses based on the side effects or the potential side effects. But unless in my belief, unless if you start at the appropriate starting dose, you may be giving an ineffective or less than effective dose without knowing if it's going to be toxic or not. So in my practice, I start at 20, and I'll go down again appropriately and liberally for dose reduction indications. But I do think that 20 milligrams is the right dose to start at.
Yeah. What do you guys think, Tom?
Yeah, I mean, this is a really challenging subject, and there's I found two camps in the world, right?
Only two?
Only two, right?
There's the purists that go with 20.
Yeah.
And then you have I'll escalate. And some people I know started as low as 4 and 8. Remember, these come in 10 and 4 milligram tablets. So it's important to think about how you're going to end up with these strange doses of, say, 14 or 18 and so forth. For me personally, if the patient's healthy, I've been starting at either 14 or 18. And if they're pretty good performance status and so forth, I usually start at 18. If it, at 18 and see how they do. To me, that's enough of that you might not have the hypertension. The other thing with that is they've noted that there were, what's the threshold, would you say, Brian? There were plenty of responses at 14.
In those patients that were appropriately reduced.
Yeah. Correct.
We're good. I love this. We're all friends.
Yeah.
What data are you referring to with the starting dose of 14?
Well, what I'm referring to is real world experience where I've started patients at 20 and they had to come off, and I just was never able to get drug in.
Yeah.
So Dave, Dr. O'Malley, you used to say, I'm going to start at 18, so they're not going to have a copay, but now that's not relevant anymore because there's a dose exchange. So now when you start it, you can still.
I love when you put words in my mouth, especially when they're wrong. All right, so
Especially when they're wrong.
Katie has one of my classic, which you say we make stuff up all the time. I try not to make stuff up. I try to be pragmatic.
Okay.
Oh, I see.
Yeah.
That's what it's called.
And then if you start at 18, knowing that 2/3 to 80% of patients are going to need to be dose reduced. So you have an exchange, but it is not an immediate exchange, and it actually usually takes couple of weeks. So if they're at 18, I need to dose reduce them. They already have the 4 milligram tabs to go down to 14. I doubt that a 10% below the starting dose is going to impact efficacy. I do believe that starting at very low doses, what do we do in the lab? In the lab, to make resistant cell lines, we give them low dose of chemotherapy to kill all the sensitive cells, so that those that are still around become resistant. Why would we do that in a human? Why would we start at 4 or 8 milligrams and not give our patients the best chance to respond?
I
I
agree.
find this conversation very interesting, and I just want to go back to historical information about dosing for various drugs, and then I'll tell you what dose I start at. So GOG 111, was that Dr. Ozol's? Carboplatinum was 7.5.
Bill McGuire.
Yeah.
Was it
Mhm.
Bill McGuire's? Okay.
Yeah.
So 7.5, right? Who uses carboplatinum at AUC at 7.5 in this room?
Yeah, we made it up.
Doxil.
Yeah.
50.
We made it up.
Doxil. Next one, Doxil, 50 milligrams.
50.
per
You're talking
gram.
about
Who
GOG
uses-
158.
Yeah.
Yeah,
Exactly.
GOG 150. That's
Yeah.
okay. So then Doxil, 50 milligrams per meter squared. Who uses that dose?
Mhm.
So we have to use the doses that we can get into patients. We had
Yeah.
the study open at our site. All of our patients got dose reduced, or at least the patients I managed, and the toxicity is real. And you know, if they have the elevated blood pressure or the diarrhea, or the rash, then you have to hold the drug. And so I like to start at a dose of 14. This is a data-free zone. In my opinion, this is a really important area that we need to do further research on. And Dr. Leslie Randall has a study that she's going to try to do on this dosing to provide further clarity.
So
Yes, I am.
We should do a show of hands by starting.
Yeah,
this.
right.
Yeah.
I want to make a comment
Go
first.
ahead.
I want to make
Go
a
ahead.
comment first, really quick.
Okay.
When we act like we don't have data at the lower doses, and we do have data
Yeah.
at the lower doses, because almost no one tolerated the 20 milligram dose. It's like,
But there may be some
Niraparib at
rationale. This was
300.
this was the niraparib discussion,
Exactly.
right? Where
right,
there's 20% of patients who may need 300 because that's their kind of dosing level. So when you looked at the kind of the pharmacokinetics of niraparib, it overlaps by individualization. So some people at 100 are at the same level as some people at 300. And so so by starting everyone at 200, you're going to underdose 20%, but you're going to have less toxicity.
Mhm.
And that may be the
Mhm.
that may be the safest way to go. And you may do the same thing with.
well, that was the end of
nivatinib.
my comment. It's just not clean
Yeah.
data,
Right.
but we
Mhm.
do have some information.
So I wanted to, there's a great question that came in from our viewers, and that was,
Oh, awesome.
the question was, if you had good disease control for 2 years,
Mhm.
would you continue or would you stop?
Pembro?
Mhm.
I saw
Well, or
a
the rest.
patient this
yeah.
week.
So go ahead.
I had to answer this question this week. You know, I don't know. I mean, when the nurses ask me how long will they be on it, I say forever. And it's sort of tongue in cheek, but sometimes I really mean it. This patient was MSI high
Mhm.
and was on single agent checkpoint. And I think that there's a reasonable chance that it probably, potentially cured her, but I think she'll at
Mhm.
least have a long disease
I
control.
can tell you,
But it's hard.
patients don't like to hear forever. So I think we
Yeah.
have to sort of couch that as long
Mhm.
as it's working and tolerable, but.
Right. Dave?
And I've had a lot of discussions with our melanoma colleagues and our lung cancer colleagues. And when they're looking at the 2-year mark,
Yeah.
most of them sounds like, and again, this is just talking.
Mhm.
At 2 years, if they have a CR, almost everybody seems to stop.
Correct.
Mhm.
Mhm.
PR becomes much greater debate,
Mhm.
right?
Right.
Now, if it's a lymph node, which is, 9 millimeters, you don't know if it's real or not, that's obviously much more challenging. If they have a CR, in my mind, it's easy. I'm going to hold them because we also know, and one of the things we've learned from our melanoma and lung cancer colleagues, if you reintroduce the IO, they seem to respond in most patients. I'm not going to say all, but most
Mhm.
patients. But I do think it's such an important question. I wish we had better answers.
If you reintroduce it in the ones that have always been sensitive.
Correct.
Yes.
Correct.
Love that.
Great point.
Uh,
Thank you.
Ramez?
I echo all the statements made. I think the DMMR population, it's an easier question for me to answer. If they're a CR at 2 years, I do advocate that we stop therapy based on the studies. I think in the PMMR, lenvatinib pembro combination regimen, that's where it becomes a little bit more of a nuanced decision. I know in the trial, the pembro is 2 years, stop, continue the lenvatinib. I have done that, but I'm also worried when I make that decision about whether there's utility in the combination together or not. But I've followed the protocol to date because, like you said, patients don't want to be on treatment forever, especially if they're in a CR.
Right. And you never know. I mean, obviously, this is all about educating the immune system as well, right? So the question is, how much education have we made?
Yeah.
I mean, is it educated against the tumor, and can you stop and expect that you'll continue to see a response? We've seen that in other tumor types with partial responses.
Mhm.
So, I mean, another great question just came in. Thank you all for sending in your questions. Please continue to send them in. We'll try to get to them as fast as possible. The question came up about an adverse event that you see with both of these drugs independently. So diarrhea. So how do you sort it out? Anybody?
Actually, the way I've sorted this out is if you start to institute some measures to manage the diarrhea, for instance, Well, it depends on severity of diarrhea. Like if they have
Okay.
bad diarrhea,
Yeah.
you don't mess around with that. That's
Mhm.
admission, hydration, GI consult if it's very severe.
Assume the worst.
Start the
right.
steroids, yes. But if it's mild diarrhea and you're not quite sure what it is, if you start to institute some measures like the BRAT diet and Imodium and they get better quickly, then it's most likely due to the lenvatinib. That's been
Mhm.
my clinical experience.
Or discontinue the limp.
Or hold
Yeah,
it.
hold
it.
Yeah, or
It's
hold it.
easy
Yeah,
to
That's what I
absolutely.
did.
one.
Yeah.
So Bhavna, you were going to say something?
Yeah, I echo what Angela said, and and I think, right, these are overlapping toxicities, and I think it's really important to kind of try to sort out, is it due to the lenvatinib or is it due to the pembro?
Yeah.
And right, your treatment is different, and if it is due to the pembro, it's much more serious. It could mean that the patient does need to be hospitalized. So and the other thing that's really important is you have to have really good follow-up. So if someone calls about diarrhea, you need to know how many bowel movements over baseline that
Mhm.
they are reporting, and you need to make sure that has not increased. And things can go sour very quickly if you are not on top of it and don't manage these patients because they may need steroids, they may need hospitalization.
Good.
But it's
Good.
important that most of the time, it's not that hard because the lenvatinib side effects start early,
Yeah,
cycle
timing.
1 or 2,
Mhm.
and they don't have the explosive diarrhea, bloody and crampy.
Mhm.
They have annoying. What we do, and I think, Bob, that's a great point, which is we do video visits weekly for at least the first cycle, if not the first couple of cycles.
Right.
Remember that colitis, immune-associated colitis in the first cycle without a CTLA-4 is exceedingly rare.
Mhm.
Mhm.
So in the first cycle, it's almost always going to be lenvatinib, and you're going to know what their baseline is and try to maximize the medical management.
Mhm.
If then it changes cycle 2, 3, 4, or forever, then that is much more concerning to me with regards to immune-associated colitis.
Dr. Morgady, if you had a patient MSI high that was getting dostarlimab or pembrolizumab and progressed, would you add lenvatinib to it to overcome that resistance?
I don't know that we have data for that. I've heard a lot of people doing that.
Yeah.
Mhm.
But I might consider it. I've never done that actually, because we have clinical trials open for patients. So I would move them to a clinical trial in a
Yeah.
post-IO setting. Off of clinical trial, I don't know that there's any data that tells us that it overcomes the mechanism of resistance.
But Brian, you showed a nice abstract in the DMMR population.
Mhm.
It's not exactly that question, but
But it's
Merck-
versus
yeah, I get
chemo.
it.
Merck
Good.
Eisai. This is the trial that needs to be done. There is no debate.
Yeah.
Why are you debating it? Do the trial.
How do you
You have
feel
an
about
opinion?
that, Dave?
Bhavna.
I have seen responses in
Mhm.
patients who've had, single agent IO and then went on a trial with
Interesting.
Mhm.
a checkpoint and a TKI. So, and
Sure.
I've seen responses. So
Yep.
Uh-huh.
I think it is a reasonable strategy.
Uh-huh.
Yeah,
Ramesh?
I was going to echo that exact statement. Yeah, there's other not lenvatinib pembro, but other TKI IO combinations that intended to accrue post IO progressors
Mhm.
that showed responses with the TKIO, small
Yeah.
cohorts, preliminary evidence, but certainly speaks to the fact that the trial should be done like Dr. O'Malley just mentioned a second ago. So we're all in favor, I think, of that.
Actually, I have a better idea.
Post-
Merck Eisai, you don't want to do it? I'm sure there's some companies out there who want.
There's a
Right?
call out. Oh my gosh. We're not going to start a war here. This is, we're all friends here.
No, I love you. You know I love you, but come on now.
Just a
Hey,
different
Brian,
checkpoint.
I have a follow-up question from a listener on the biomarker testing. So you talked about both TMB and the MSI MMR
Yep.
kind of thing. Do we need to get both? Do we need to get both TMB and MSI or MMR testing?
That's a great question. Right now, what's going on as far as screening in most places, I don't want to say all places, but we're doing an IHC screen at time of diagnosis,
Yeah.
which is looking for the IHC of the MMR proteins. And MSI is not necessarily included in that. I don't think we need to do both as an upfront screen. In those patients with recurrent disease, though, I would do a next-gen sequencing, which would include the tumor mutational burden. So that'll help to.
When do you get it though? I mean, is it
I would say in my advanced stage patients or those
Okay.
patients that recur
at baseline?
At baseline.
at baseline.
Okay.
I do.
Right.
Yeah.
You guys all do the same?
Yeah.
Because there's other
And the
biomarkers we're looking
incurable
for.
Uh-huh.
recurrent.
Okay. So other hits
You
on
get the
the,
panel.
yeah.
Yeah.
uh-huh.
Yeah.
I
You-
definitely do it for recurrence, but not necessarily for patients who have advanced stage disease. at this point in time. But if they, obviously if they're progressing, then I'll get it at that point.
Yeah.
But the classic example, right, is POL. So
Uh-huh.
all DMMR should be TMB,
Mhm.
but all TMB is not MMR,
Correct.
Right,
right? Because
right, that's right.
a POL mutation is a high TMB, but is
Right.
not MMR.
Mhm.
So I think, like some of you said, they're complementary.
Yep.
And the beauty of it is there are laboratory vendors that will do it comprehensively.
Right.
So don't get discouraged, right? If it's high TMB, but it's not DMMR, checkpoint inhibitors, dostarlimab, pembrolizumab, probably gonna work.
It's
Well,
5
the
to
data is pretty
7%.
small for
About
that group, but
5%.
we're never going to do a study
Right.
in we're trying to do a
Just-
study in POLI.
yeah.
It's so small.
Yeah.
TMB high, mismatch repair proficient, such a small, we're going to have
Right.
to use subgroups there, and the subgroups are compelling. So I want to know that up front.
Yeah, right.
Yeah, I mean, Ramiz and I were just talking, it's about 5%. So,
Yeah.
Mhm.
that are not DMMR, MSI high that you'll pick up. So that's another 5% that could benefit from IO.
It's not
And
an
it's an
Right.
approved
Right.
therapy
Right.
for
And
this
there's this
patient.
whole narrative that all DMMR patients are not the same, right? That the genetically mutated, the Lynch or Lynch-like,
Mhm.
have a higher
Yeah.
activity because it's more difficult to reverse
Mhm.
than a promoter hypermethylation epigenetically silenced.
Mhm.
Again, that narrative is also being written, but I encourage you, Brian,
Yep.
when these trials, read out, maybe even 309-775 to sort out those subsets to see if
Mhm.
there's really a difference. And it's probably about 70-30.
Okay.
So 70 MLH1 promoter hypermethylation, 30% mutated.
Mhm.
And Brad, you bring up a really good point because our trials should probably really stratify by MLH1
Yeah.
methylation.
Yeah,
If
that's
it matters
good.
that
And
much.
Through, yeah.
And and
Yeah, because-
lenvatinib is the best opportunity for the non-genetically
Absolutely.
altered.
Yes.
Right.
Right.
But do we know that it matters that
No, we
much
don't
to
know.
stratify?
Not yet.
right?
Not
I'm
yet, but
taking the
data's
O'Malley
coming.
approach,
No,
the
it's-
pragmatic approach.
Yeah.
Well, that's
we don't
what
need
I'm saying.
data. We just need
Pragmatically,
to, we just need to make it
it
sound good.
works.
Preliminary data
Yeah.
that
Yeah.
that was presented at,
Mhm.
right, at ASCO.
So we got about 30 seconds on this section, but I wanted to, Brian, maybe you could get, because I got a question about why are we combining PARP in those, in Ruby and in DOE? What's the rationale behind it? Just quickly.
Yeah, that's a great question. There's some, and one of the studies is Katie Moore's study with Shannon West in the DOE. There's preclinical rationale that it could be additive, if not, or synergistic, if not additive, to the whole, to the chemotherapy with the checkpoint, particularly in a subgroup of aggressive endometrial
Mhm.
cancers or the serous-like, which may have some of the HRD-like features. So
Makes
we're-
sense.
makes
Yeah.
sense. Yeah.
Okay, great.
So
Great
we're gonna,
discussion, guys.
that was great.
Yeah.
We're gonna divide the ovarian into two, frontline and sensitive, and then platinum resistant. Before we get to that, though, we get to hear about cervical cancer, Leslie Randall,
Yeah.
who is our cervical cancer lead. And my pleasure to introduce Dr. Leslie Randall from Richmond, Virginia. Thank you, Leslie.
Thanks, Brad. So it's my honor and privilege to help you and your cervical cancer patients by representing this portfolio. So unless you've been under a rock, you know that also, and maybe you have, you also know that in addition to the endometrial NCCN guidelines, the cervical cancer guidelines have been updated. And you see two new players on the guidelines, pembrolizumab in the front line and tisotumab vedotin. And really, these are reduced down to two little boxes on this slide, but this represents the work of many, many investigators and patients and over the course of about the last 5 to 6+ years. So this is the not a GOG study, but probably one of the biggest highlights of the fall, Keynote 826. And this is a phase 3 randomized trial testing pembrolizumab in the GOG 240 space. And so this enrolled the same population as our GOG 240 study and stratified patients by whether they had primary stage 4 disease. They were stratified by their CPS score. There were 90% PD-L1 positive patients in this study and about 10% that were PD-L1 negative. That becomes important later for the approval. And then the Bev use was optional. And I think we all know that even though we want to give all of our patients Bev, some of our patients aren't candidates for Bev. And the breakdown for Bev use in this study was 60-40, 60 patients receiving Bev and about 40% of patients not receiving Bev because of ineligibility for Bev. And so that was equal between both of the study groups. And here are the results. So you can see no matter how you split it, whether patients were PD-L1 positive, negative, and even if they had a high PD-L1 positive score, there was a benefit of pembrolizumab in all of the groups. And this is the progression-free survival curves. And here you can see hazard ratios in the range of 0.6. And this study was actually closed at its first interim analysis for efficacy. So very exciting. If you look at the forest plot, I don't know if my laser pointer shows up on this or not. No, it doesn't. That's the back button. Okay, so PD-L1 negative patients, the hazard ratio on the forest plot crossed 1. And although this isn't really a statistically valid conclusion, the same was shown for overall survival, and the FDA approved pembrolizumab but restricted it to PD-L1 positive patients. So in your PD-L1 negative frontline patients, GOG 240 is still the standard of care in this space. And GOG 240 is the only trial that informs the use of bevacizumab in this population. This study does not inform the use of bevacizumab. So I'm a little passionate about it because this group, you on this program know how important the GOG 240 study was that Dr. Tewari led back in 2013. So this does not mean that you can not use pembrolizumab or not use bevacizumab. This means if you can use bevacizumab, you should, because you can also see on the forest plot here that those patients who received Bev did better than those who did not. But if patients are not candidates for bevacizumab, you can feel a little bit better about it by giving them pembrolizumab if they're PD-L1 positive. Of course, the problem here is what about our PD-L1 negative patients? And so that remains a population with unmet need. This is our GOG trial in this space. We are collaborating with GEICO and NGOT. GOG 3030 Beat CC. We have 7 wonderful, amazing sites who carried this protocol here in the United States. This is atezolizumab instead of pembrolizumab, a PD-L1 inhibitor in this space. And this is Bev mandatory between both arms. And otherwise, this study is very similar to Keynote 826. Now, PD-L1 positivity was not a stratification factor in this study, but it will be looked at retrospectively. So what happens? I mean, this is going to change the world, right? Well, it's mostly going to change the world, but what will probably really, really change the world is when our single agent checkpoints move into the locally advanced cervical cancer space. About 75% of our metastatic population is a result of failure of chemo-RT. And we are looking at durvalumab, not a GOG study, but the study CALA, which has already closed. That was modeled after a lung cancer trial called Pacific, where there was a major difference in overall survival with the addition of durvalumab maintenance after chemo-RT. And we're studying this in the GOG, and Linda Duska and Rita Solani are the PIs of GOG 3047, Keynote A18, also a collaboration with NGOT. So this is very exciting, and this probably will really change the world for cervical cancer, but these trials are ongoing. So the next red box you saw in the NCCN guidelines is a new drug called tisotumab vedotin. So rarely in GYN do we approve a new class of drug, a brand new drug approval in GYN. I think dostarlimab was the only other drug that we launched in GYN. But tisotumab vedotin is just that. It's antibody drug conjugate. It's against tissue factor, and the payload is MMAE, and it's a taxane-like tubulin microtubule poison. And the study that Dr. Coleman here led in the GOG 3023, and that you all performed, enrolled patients in the 2nd or 3rd line with measurable disease and treated them with tisotumab 2 mg per kg IV every 3 weeks until progression or unacceptable toxicity. And this was an accelerated approval opportunity. So the primary endpoint was objective response rate by RECIST. And these were the responses. 7 complete and 17 partial responses for a combined rate of 24%. And interestingly, the median duration of response was 8.3 months, which was much better than the benchmarks in this space, which were on the order of single-digit response rates and single-digit durations. This clearly stood above the rest, and those old drugs still sit on the NCCN list. And if you notice, tisotumab is at the bottom of that list, not because it's the least active drug, but because it's the most recent one to be added. So, so there was a PDUFA for FDA approval of this drug for 10/10, but it got approved on September the 18th. So it's a new drug to all of us, and we just need to look at its toxicities. If you look at it, all of its toxicities across the board, most of them are grade 1 or 2, and the most common one is alopecia, followed by epistaxis and nausea. But there are AEs of interest with this drug, and most commonly are the ocular adverse events. And so if you go back to that composite side effects and add up, there are several different ocular adverse events. Most of them are surface, conjunctivitis, keratitis. Most of them can be noticed by you, but this drug has a box label for an ophthalmologic exam. We gotta even learn to say that. Ophthalmologic exam every 3 weeks with every single cycle. So whereas you're getting, where you used to get echoes for Doxil before you could give a dose for every dose of this drug, you have to have an eye care professional exam, and that can be an optometrist. It doesn't necessarily have to be an ophthalmologist. They need to be able to do a slit lamp exam and a visual acuity, which most, even your Costco, Walmart optometrists are capable of doing. Bleeding and peripheral neuropathy are of concern with this drug. And I think that in the long term, probably the side effect of the most concern will probably be peripheral neuropathy, but we need more post-approval experience with this drug. Now, you guys are awesome and put about 30 patients on this study, GOG 3057, which Brian Slomovitz has been leading for us in the GOG. And this was a phase 3 confirmatory trial of tisotumab versus investigator choice chemotherapy. And with the FDA approval, this trial will close in the United States, and our NGOT partners and collaborators will be finishing up this trial. So what's next? Brett, we talked about the future. Brad Monk is leading this trial for us. This is TV in combination with several different drugs, both in the second line and in the front line. So if you go from left to right on this chart, this study looked at dose escalations of TV in combination with bevacizumab, pembro, and carboplatin in the second line, and then looked at frontline expansion cohorts for TV with pembro and TV with carboplatin, and in the second line, TV with pembro, and then had looked at a weekly dose of TV, much like we had done with weekly Taxol. Now you look at the front line and think, wow, like, you know, why wouldn't you give the 240 regimen in the front line? And I think our patients are kind of hungry for some dose de-escalation protocols in the front line. And so that was the rationale here. And these are small cohorts just to get proof of concept. Brad presented the toxicity dose escalation data on the left at the IGCS this year. And you can see that, and you can't see it here in this slide, but all of these drugs were able to be escalated to their fully tolerated single agent doses as combinations. So that was reassuring. We thought there would be overlapping toxicity for bleeding with Bev. We thought there would be overlapping neuropathy with carboplatin, and that doesn't seem to have occurred. And if you look back at Rob's study in the GOG 3023, the toxicity seen with the combinations was very comparable to that seen with the single agent. So Dr. Vergote presented the some preliminary data on efficacy for a couple of these combos. So this is the first line group with TV carbo. You can see that the confirmed response rate was 55%, getting close to what we saw in Keynote 826, about 60% in that group, and also on par with what we saw in GOG 240 as well. The AEs were about comparable to what we saw with the single agent. And here the duration of response was 8.3 months, as seen in the second line. And then to me, this is what's really exciting. The second, third line combination with pembrolizumab. Draw your attention to the confirmed response rate of 38%. And so I think I probably expected it to be a little bit closer to TV alone. And I expected pembro maybe to drag that down with a 14% single agent response rate in this space, but here you've got 38%. So I think there might be some synergy. This is PD-L1 agnostic. We have no idea what the PD-L1 status. So that's something to watch in the future. Moving back to immunotherapy, just to review, if you hadn't seen this, the GOG performed the Empower study. Chris Chouari presented the results of cemiplimab versus physician's choice chemotherapy at an interim ESMO meeting and showed an overall survival benefit of cemiplimab, another PD-1 inhibitor, in the second and third line. And this is the only phase 3 data we have for single agent checkpoint inhibitor in second and third line. Now, you may look back at 826 and say, does it matter now that we'll be giving pembrolizumab in the front line? You probably won't give it to everyone. You won't give it to your PD-L1 negative patients. Can PD-L1 negative patients get cemiplimab? I don't know is the answer. Here is the survival analysis that Dr. Chouari presented at ESMO this year, showing a benefit of the patients that were PD-L1 positive did better with cemiplimab, but patients who are PD-L1 negative also did better with cemiplimab than they did with chemotherapy. So it'll be interesting to see what this is in front of the FDA with the PDUFA date at the end of January. And the PD-L1 status was assessed by a different assay than was in the 826. And so I think we're learning about PD-L1 as a marker kind of as we go, building the plane at 30,000 feet, if you will. So something to look for. This is really exciting data. And I don't want us to think that we're done, because I need to have more trials, because now my trials are done and Brian has all the trials and Dave. So I need more trials so I still can keep my job. And I don't think we're done. And of course, we still have our PD-L1 negative population really to address. He has still a high unmet medical need. Dave presented a combination of an anti-PD-1, CTLA-4, balstilimab, zalifrelimab at ESMO this year. And he's been working on this for quite a long time. And you can look at the top, the clinical activity and the objective response rate is 25.6%. And in the bars, you can see in the waterfall plot, you can see the dark blue bars are PD-L1 positive, the light blue are negative, and the gray are unknown for patients who did not have sufficient tissue for PD-L1 testing. And you can see here that this shows activity really more across the board. And so maybe this is how we go back and pick up those PD-L1 negative patients, in addition to maybe potentially having even better activity in our PD-L1 positive patients than we have with single agent checkpoint. We don't know that yet, and that remains to be seen. I'm just here to argue that we should continue to study this. This is the progression-free and overall survival time seen in Dave's study, and you can see in the overall survival curve, a median overall survival of 12.8 months. So, I mean, just pause for a second and think back to before GOG 204, where we picked up platinum taxane, before GOG 240, where we picked up Bev. And here we are in the second line. A patient who walked in with metastatic cervical cancer really had an overall survival time in a matter of a few months. And here you're talking about 2 years with pembrolizumab in the front line, 12 months with these therapies in the second line. So now we're looking at collectively 3 years. So you're doing and helping us with this really important trial, GOG 3028, balstilimab versus Balzal in the second line only. And this study is interesting. It's randomized. It's not to compare the efficacy of the single agent versus the combination. It's really to look at more relative toxicity that the Zal adds to the combination. And if your patient is a candidate for this study, don't feel bad about putting them on balstilimab because they should get pembrolizumab. If they're not checkpoint exposed, you can look up a publication in single agent balstilimab that we have in GYN oncology and see that the response rate to balstilimab alone is comparable or better. Well, I shouldn't say better. It's comparable to pembrolizumab in the second line. So this is the projected treatment landscape. I think locally advanced disease, still the standard of care is chemoradiotherapy, but I think chemoradioimmunotherapy is coming Most of you know about the Outback trial that was presented at ASCO, that adding 4 cycles of chemotherapy after chemoradiation was a negative study. But I think immunotherapy really has the potential to move that needle quite significantly. And then in the metastatic setting for your PD-L1 positive patients, Keynote 826 is now the standard of care. And then for the PD-L1 negative, GOG 240 remains the standard of care. In the second line, it really probably matters if they've been exposed to checkpoint inhibitor or not. And so for those patients who've had no prior IO, my first choice for them would be GOG 3028 or the RAPIDS trial. After that, according to the NCCN guidelines, if they're PD-L1 positive, you can consider pembrolizumab or nivolumab, and then tisotumab vedotin. For patients who have had prior IO, which eventually will be most of our patients, tisotumab vedotin in my mind is really the go-to next choice. And you can see in yellow here all of the options and needs that we have in this space. And so this is how I keep my job, is by continuing to run these trials. I think that's it for me. Great.
Thank you, Leslie.
you.
That was great. That was great.
Thank you.
So let's break it down by line of therapy. And thank you again. That was a wonderful presentation. Let's talk about this first line, and we don't mean chemotherapy and radiation. We mean the 204, 240, 826 setting. I'm just gonna, anybody, when would you not use pembrolizumab according to the 826 study? When would you not? In other words, is it for everyone? Assuming there's not a contraindication. I get it if there's a kidney transplant. I get it. Okay. But that's not a good.
PD-L1 negative.
Okay.
Okay.
One
There
negative.
you go.
But that's
Yeah.
only,
That's it.
that's only 11.
Like, yeah,
Yeah,
10%.
10%.
Right,
Yeah.
right.
Or
Right.
89% were.
Yeah.
So how
PD-L1
long,
positive.
Bob, do you think it's going to take for what Leslie said? Well, where 89%, let's say there's 5% that have a kidney transplant or a contraindication, where 85% of the patients in the second line are going to be checkpoint exposed. How long is that going to take for that uptake?
Well, it's going to take education. So I'm
Yeah.
glad we're doing
Mhm.
this highlight reel.
Right.
And it's going to also take patients coming in to get this therapy, right? Like we have to
Right.
think about this patient population. They're not always going to come in and be able to get the immunotherapy.
Yeah.
So, but I think, within a year or so, we should all, patients coming into our centers should be getting this therapy.
I think so, right?
It may
In my
even be
mind, it's on the same
faster.
schedule.
Yeah,
So, if they can come in for platinum taxane, they can get the pembro. It is a long day,
Mhm.
right? Those of us who have given the
It is a
quad,
long day.
Yeah.
it's a
Quad.
long
Yeah.
day.
But
Go
it
ahead,
may
Howard.
be
That's really-
faster uptake than some other drugs because it's
Yeah.
already on formulary at so many hospitals.
Yeah, right.
And that's
That's-
different than when PARP inhibitors were first approved. They
Uh-huh.
weren't on
Good point.
formulary, and
Yep.
tisotumab
Oh.
vedotin is not on formulary.
It's
We're
easier
having to
for it to
ask for
switch,
this.
yeah.
Yeah.
Okay.
Yep.
So it's very quick to make the switch.
Ramesh?
So GOG 240 was transformative. Keynote 826 transformative. We have
Yeah.
experience with Pembro. We've been using it for several years. Patients are familiar. I think this should pick up right away. And I think we offer it to our patients because it is the best opportunity to improve their outcome.
It's so funny you say that. I was put together a slide about, the importance of clinical trials. I was giving to a general audience, and I pulled up the historical, metastatic cervix GOG experience with, one, going way back to the
169.
169, 179, 204, 240. And you can see that when we finally got into the biologic, and it was basically flat for
Right.
decades,
well,
right? And
under
now it's
12
gone up,
Yeah.
and we haven't hit the median OS from Keynote 826.
Yeah.
So it's really fascinating how much of a difference we've made with the incorporation of the biological component.
Tom, tell us about biomarkers. So, what Bob has said, well, PD-L1 negative maybe aren't going to get it. It's not indicated or probably reimbursed.
Mm.
What does the biomarker testing landscape look like in cervical cancer, and when should you do it?
Yeah, well, I think with this data, you have to do it on everybody.
Mhm.
And one of the things that needs to be understood is the PL1 testing can be difficult in
Yeah.
some ways.
Mhm.
It's, if you look at the variation between the studies. So
Mhm.
for 826, it was 89%, but it was much lower in a number of studies, almost half that in some of the earlier ones. So there's some subjectivity. The other thing is this combined positivity score, of greater than 1. That seems to be predictive. What's really interesting in the 826 data is that if you were greater than 1 versus greater than 10, it didn't make a
Didn't
big
have much
difference.
incremental
Yeah,
difference,
it was,
right? No,
there's
not what
a
you would
low
expect.
threshold there for activity, so which is great. So I think everybody should be checking.
And Dave, you had a comment, and then we'll move on to second line.
You know, we say, you know, what's the unmet need? And the unmet need really is curing more people,
Mhm.
right?
Mhm.
And if you look at that flattening of the curve, one of the hallmarks of immunotherapy is that prolonged response and survival.
Mm.
We may be curing 30% or just under 30% of patients with metastatic recurrent cervix cancer. Clearly, it's not mature data. This is only the first interim analysis, and we have a lot more time.
Yeah.
But
Mhm.
why would we hold the therapy to the
Yeah,
next
dude,
line?
I'm with
And
you.
I'm not laughing at it.
Yeah,
It
it's
seems
so
so
crazy.
fundamental to what we
Yeah.
do as cancer doctors to
Yeah.
treat cancer.
And to,
Yeah.
and to try to
Get your
cure
best drugs forward.
people
Yeah.
from their cancer.
Yeah.
Right.
And
Yeah,
so that may make
agreed.
this a moot point. I know you want to move on, Brad, but I
No,
just want
no,
to
go
mention
ahead.
one thing,
ahead,
because
go
I
ahead.
think this is what I'm struggling with, and a clinical question for me is the quadruple treatment.
Uh-huh.
And Bev in there, and maybe it's an additive benefit, but this is tough for me because I do think that we have to consider the cost of these therapies too on a
Mhm.
bigger scale. And I hope that we can find a biomarker to direct Bev someday. That would be my dream. But it's been a challenge. I mean, I'm using the 4 drugs. Some patients it's easy because Bev is just not something you would utilize in that patient if they are actively fistulizing or have another contraindication.
Mhm.
But this is kind of a struggle.
It is a struggle. And I've said this many times, and I think, Leslie, you sort of said it maybe better. We already figured out who to give Bev to.
Mhm.
We figured that out over the last 7 years. And 826 does not inform that. 826 is a Pembro study. And so if you're a Bev believer, then use it. And if
Mhm.
you're not, don't.
Mhm.
But let's not let Bev get in the way of using Pembro.
Oh, I don't think that's happening at all. I think most people are probably saying pembrolizumab chemotherapy, but the problem is that's not what the study didn't address, that addition, right?
Mhm.
So I think it's still a conundrum. I think it's
Agreed.
going to be a great opportunity to debate further in other sessions.
Go ahead, Bob. now.
I was gonna say, but that's not what I'm hearing. I'm hearing people saying they want to hold the IO until recurrence because they don't want to use up all their drugs in the front line. But I
We've-
say to that,
We've got a whole
your
list. of
first
Oh,
really
yeah.
great
shot
drugs.
is your
Yes,
chance to
yes.
cure.
That's right.
And this
Yeah.
is not ovarian cancer where you can use 5, 6 different drugs. You want to use the best drugs up front.
Yeah.
So let's talk about recurrence. And Leslie, I'm going to ask you a tough question. We're friends. So,
There's the preamble.
We're friends. So for now, we're going to have most patients in the second line that are IO naive. Okay.
Mhm, right.
Can you justify getting an all-comer label for cemiplimab? Because, and specifically, like you said,
Mhm.
Empower did not really test the question.
Mhm.
They didn't test it.
Mhm.
So is there a halo effect that if it applies to Pembro, it
Mhm.
must apply to cemiplimab? And I hate the halo effect. I hate the idea, I'm just going to say it,
Mhm.
that we had a negative ODAC for study 19.
Mhm.
And because Nova was positive, I guess the negative ODAC in the phase 2 trial in study 19, that counts. And I think every agent, every trial needs to be judged independently.
Mhm.
So I guess what I'm trying to ask you, do you think cemiplimab should be an all-comer approval, or do you think there's I think I already influenced you, and I don't mean to.
No.
What do you think?
No, you can't.
Oh,
I'm gonna stand on my own. My own
There you go.
answer.
Push back.
Even
Look,
though
push
you
back.
trained
There you
me.
go.
Yeah.
Yeah, that's right.
I think, I don't know. I think about it a lot.
Yeah.
When you
Mhm.
look at the data, when I looked at 826, I thought they'll have a hard time not giving it an all-comers indication. Is that even if they look at the PD-L1 forest plot, the PD-L1 negative forest plot, it's only 11% of the patients. You
Mhm.
can't really draw a conclusion based on that small of a population. So they'll just have to approve it based on the intent to treat, and everybody will get it. So that's what I thought would happen, and it didn't happen. So the short answer is I have no clue. I'm not good at predicting.
We're all looking.
But
Yeah.
interestingly, so when we wrote it, I didn't write Empower. When you all wrote Empower, we didn't have this sophistication around the
Oh, right,
PD-L1
yeah.
biomarker. We didn't know that the FDA would restrict the accelerated approval of Pembro to PD-L1.
Mhm.
So it wasn't written into the trial prospectively.
Yeah.
And it's going to be very difficult to go back. The data that Dr. Tewari presented at ESMO, like what, half at best of patients were able to submit or we are able to get
Yeah.
tissue for
It's not-
PD-L1,
it
it's
didn't
probably
test
not
it.
going to
Yeah.
be possible.
Different antibody, and they used a
Right.
tumor score, not a combined score.
Correct. And they're probably even, it's probably not going to be possible. So if they're going to
Right.
approve it at all, I think they're going to have to approve it for all.
Yeah. Well,
So I'm gonna phone a friend and ask for help, backup, as I always say. So Dave, you've taught us very well that checkpoint inhibitors work in PD-L1 negative patients, right?
You know, I think as we look at this, obviously the efficacy is not as robust as
Right.
as
Yes.
PD-L1 positive.
right.
But when we look at the options available to our patients with PD-L1 negative with the cytotoxics, your response rates are single digits, very consistent,
hmm
right? Very consistently. So we see activity in PD-L1, but not nearly the robustness. So again, we were all surprised that 826 didn't get full approval. Our FDA, they've done an amazing job of bringing more drugs to our patients the last 6 years. But they love biomarkers.
Mhm.
And so I wouldn't be surprised if they followed suit here, but
I
we
agree.
know it works. In Rapids,
Mhm.
shameless plug, Rapids,
Plug,
you're allowed to enroll PD-L1 negative
Right.
patients on that trial.
That's right.
So we have a question here from the audience. 6%, I think, was chemotherapy in Empower. Someone says,
Yeah.
really that bad?
Yeah, it's really that bad.
Yeah.
There's the evidence. I mean,
And even
That's it.
though checkpoint may not be that great, it's at least as good as
It's
chemotherapy.
at least as good and
It's
less
gotta be better,
toxicity.
yeah.
Go ahead,
Isn't
Tom.
it, Tom?
So I'd love to hear what people think about the morphology of those curves. Did you
I
see
agree.
for like almost 5 months,
Yes.
there's no separation?
I know,
Right.
right?
between them.
Mm.
It's almost like immune therapy.
But
Yeah,
more
yeah.
so than what we see
I know.
with Keno 826.
It's
and
true,
any
though.
of the
Yeah.
other ones. It's
Yeah,
a
those
different
separated and
shape.
stayed.
The-
Yeah.
And just for context, since the PD-L1 biology was evolving, we restricted the enrollment as the trial went on in Empower to squamous because we thought they were all going to be PD-L1
PD-L1
positive, which
positive.
is not true.
Right.
Okay. And in fact, it worked a little better in the adnos, although it's not analytic. So
I
we
think
have a
there's-
lot to learn.
I think we have a lot to learn. I think the biomarker question for cervix, we may not answer, but the stability of PD-L1 testing in archival tissue is in question. And
Right.
so-
Mhm.
Yeah,
Great point.
So
absolutely.
cemiplimab, what you
That's
weren't getting
correct.
new biopsies
Right.
appropriately. I'm not being critical. You used tissue from years ago.
Right.
Keynote has proximal,
Right.
mostly proximal tissue, although some
Yeah.
of that may have been archival as well in the recurrent patients. I actually don't know. That would be something interesting to understand a little bit
Yeah.
better. But I think for the cemiplimab study specifically where, it's second line and the tumor is kind of old, it's just not going to be an interpretable.
Yeah.
Who's negative? I mean, you don't even know that they're really negative.
So I think what I'm hearing you say is if it's an old biopsy and they're negative, they could have decayed and
Mhm.
maybe a more
That's right.
proximal biopsy would be
And
positive.
actually,
Right.
some of
That's why I
the,
wouldn't exclude them because
right.
you're probably excluding patients that might benefit unless
Yeah.
you get a proximal biopsy, which
Right.
sometimes is just very difficult in
Yep.
cervix.
Oh, yeah,
And,
absolutely.
and many of the negatives, I think, are adenocarcinomas, which might, back to our prior discussion, really be stage 2 endometrial cancers, which might be MSI high or TMB.
Oh, boy.
Yeah.
Oh, boy.
I don't know, but I do think that, at this point,
That's true.
we're starting to incorporate this particular dynamic into our current trial.
Mm-hmm.
So that
Yeah.
older biopsies are required now to have a repeat
Yes.
that's more contemporary. So just to answer that question.
But I
Dave?
think, Brad, you threw this out for point of discussion, but it is actually very interesting. With regards to the tissue testing,
Yeah.
I now not only check PD-L1, I'm saying off for NGS
Mhm.
Yeah.
on
Absolutely.
Yeah,
our
lots.
patients, but it's particularly important on our adenocarcinomas
Mhm.
because of that concern,
Right.
making sure we get TMB and making sure we get MMR.
You might even get an EGF
Yeah.
Yep.
Yeah, right.
or a
exactly.
HER2.
Or
The
her-
HER2.
Perfect
HER2.
theory, yeah.
Yes.
Or
Perfect
HER2, yeah.
theory, yeah.
Yes.
So Brian, you have a lot of experience with TV, and I asked the sort of the tough question: who's not appropriate for 826 pembrolizumab? We had lots of support and on in that. Who's not appropriate for tisotumab vedotin, or do you give it to everyone second line? How do you sort that out?
Yeah, so that's a great question. I think that it's gonna we're still learning. I mean, I have experience from the first in human trials with it, and a lot of us in the
know.
room have treated it a lot. So I think you have to get, the clinician has to get experience in giving it. You have to
Yeah.
work out the ocular mitigation strategy. You have to best prepare for the patients. Once you're comfortable with treating the patients, I think the answer is yes, second line for those patients that went through 826. But in those patients that are PD-L1 negative and maybe getting and not getting a checkpoint in the first line, then there's a decision. Do you give TV second line, or do you give one of the checkpoints that may have better activity in the second line? The nice thing about TV versus the other agents that are being investigated, including IOs, TV is the only one that allowed for prior IO therapy.
Right.
So there's no data on IO after IO. And when you look at the breakdown, the IO events data, at least the IO events data was presented a couple years back, it didn't allow for prior IO. So with the wide use of checkpoints in this population, TV is a good option even for those patients.
And Angeles, what you write and do and talk about, the high cost of healthcare is very impactful to me. And I love what you and your Laura Havaleski and your team write. Can we justify the expense of tisotumab vedotin? I mean, at least Pembro in frontline, I can see that there's a survival advantage, but is it worth, and I get it, it's rhetorical, but you always have such good insights here. Is it worth the expense? It's I don't know. Because and the only reason, because the question right here on my little laptop is what
Somebody asked the
So I
question.
just want to give Dr. Laura Havaleski the props for all of that work.
Absolutely.
Yeah.
She's the brain power behind those studies. So I would say this is a different issue because the data that we have on TV is just such a small
Right.
study, and it's based on response rates. It's not comparative. So you would be doing like a hypothetical cost analysis, not based on any, or cost effectiveness analysis, rather than being based on data in that situation, which I don't necessarily recommend. And then the other aspect to it is I don't even know what the price point is going to come in for TV.
Yeah, you
And
can
so-
Google it, but
Yeah,
right here,
yeah.
this person says it's $113,000
An
an
infusion.
infusion, which it's not.
Yeah,
Yeah,
that would
It's not.
that would
Yeah.
be
Yeah, that's
crazy expensive.
Yeah.
Maybe
the-
for
but
a
the
year
point
of
is-
therapy, but that would bring it in similar to the other drugs that we've talked about already. So
Yeah.
24% response rate is pretty remarkable in that patient population.
Yeah. And
And
duration response too, right? Over 8 months.
so I
Dave,
can't, yeah.
Yeah, David.
I got you guys fired up. You can't see them, but they're all like.
Yeah. No, they actually
Oh, they
can see
can
it.
see them.
I'm going to be, I'm first going to be not controversial. Then I'm gonna be
Oh,
controversial.
okay. There you go.
The pricing.
And David Cohn has, but now let me digress. Actually, give me a second here. I got to collect myself.
Okay.
All
I
right.
Go to somebody else and come back. to you.
Many of our patients are young with young kids at home. They're in their 30s. Okay. 24% response rate with duration of response to get another holiday, to get another birthday. What cost is that?
Yeah.
Okay. Now, look at the impact on cervix cancer in dollars spent in the United States. It's minuscule. Here's the well, Dr. Havaleski has done amazing work. Dr. Cohn, my partner, amazing work in looking at this. And David, we were meeting with a group of investigators and said, O'Malley's the gas and I'm the brakes. I thought that was really, really interesting, right? I'm like, let's get us pay our ability to prescribe these drugs to our patients and let us help us make the decisions. Saying that, the impact on the overall healthcare dollars in the United States of cervix cancer patients and recurrent are minuscule. You know what CEOs of insurance companies, insurance companies, I misspoke, are making?
Yeah.
Okay. This is where when you're talking about
right.
withholding therapy in a 30-year-old recurrent cervix cancer because it costs too much.
Let's do
I'm
a
done.
scan.
All right, well, yeah,
Just
yeah,
a
scan
quick
first,
comment,
yeah.
because what Dave says fuels me a bit, but 6% standard of care chemo, did we not just say that a few minutes ago?
Yes.
If that, it's it.
Yeah.
Which is nothing. We have a drug that can offer them a 24% objective response rate. That is meaningful, that is impactful, that is a direct impact on them potentially. Second issue, quickly, we are not healthcare economists. We don't make the price of drugs. We don't decide what reimbursement costs are. What we get in our hands is, can I prescribe it or not?
Right.
I will prescribe it. My patient,
Yeah.
if their insurance covers it, they get it. I don't make that decision.
And what's the best treatment?
Yes.
What
Yeah.
is? What is?
I love it.
A clinical
The trial,
trial.
yeah, there you
And a
go.
clinical trial
Well,
doesn't cost anything.
Anything.
But
Go ahead.
Well, I
Brian.
mean,
remember,
well,
standard of
our
care has to
mission
be
is
covered.
to decrease deaths due to gynecologic cancers. So we can't go on without saying that the best way to decrease deaths in cervical cancer is from early detection and screening and
Mhm.
vaccination.
That's right.
So my approach is a little different, less controversial.
Prevention.
As long as the dollars spent on these medications, which are vitally important, get to next Christmas, get to next holiday, as long as we're not taking from the purse or the pocket that's being allocated towards those interventions, we should help these women live forever.
Yeah.
But we still have to focus on the most impactful way of decreasing deaths from this disease is through these other mechanisms, is
That's a great point.
number one.
So
I
Katie,
agree.
you do wonderful work in phase 1 and combinations. And Leslie presented this interesting idea that both labels of IO, Pembro, and tisotumab vedotin are silent on the combination. And you said that we could give them together.
Mhm.
So does it make it, and now we're talking, I'm leveraging this expense issue because if you use 2 biologics, it's double the price at least. So does it make any sense in the IO naive patient to give Pembro, tisotumab vedotin together? Because the response rate is now 38%,
Mhm.
which is what you said,
Mhm.
without any overlapping toxicities.
Yeah, so I would say, again, I agree with Dr. Eskander's point that if that were proven, and we have some
Okay.
initial data,
Okay.
we need some bigger numbers. If that were proven, then I would say absolutely I would use them together, but I'd move it up.
Yeah.
There's not going to be this population of IO
Mhm.
naive patients a year from now. That's going to be just like PARP naive, that's gone. So it's got to move up. But I'm interested in that. I mean, I
Yep.
think these antibody drug conjugates are replacements for chemo.
Mhm.
And I'm interested in replacing chemo.
So the GOG has a study now with 826, right? But replaces the paclitaxel with tisotumab vedotin.
Right.
So
Yep.
you can get carbo, TV, Pembro, Bev,
Bev.
all paid for on a clinical trial.
Mhm.
And that's the best treatment.
I would offer that to patients in a heartbeat.
Yes.
I know, actually, I
Yes.
was just working on that and you're going to open that study like very soon. And yeah, real fast. Yeah, I know it.
I
That's
love
why you do what you do, right?
Mhm.
In Oklahoma, right? You can offer these exciting medicines to patients through clinical trials.
Yep.
And that's our mission. And that's why we're here today.
Right, and I didn't mention that, so people are probably watching are probably confused. So that's a new arm
A new
of
arm.
the GOG 3024 study.
Thank you for that. Leslie.
Right,
Yes.
you got it.
Mhm.
All right.
We got about like 60 seconds. So I wondered, Leslie, you highlighted this in a call out reference to bevacizumab in the subgroup analysis, but we've heard all kinds of people look through those subgroup analyses and said, hey, it looks even worse in the metastatic versus recurrent. So they're saying, well, maybe I only use it in the metastatic, or maybe I don't use it in the metastatic. What do you think? How do you answer that?
Well, I mean, there's like a way that I answered it, and then there's the Rob Coleman.
That's what I'm talking about.
Which nobody can understand.
Oh, no, you're standing. She
can stand on her
Only when
own.
she talks to you. She's not me. She's falling.
The right way to answer it is the Rob Coleman school of how do you really interpret the forest plots. And I love how you teach this, because everyone who's watching can go to the New England Journal publication and will learn what that gray band means
Yeah.
on the
There you go.
forest plot. And if the whatever bar you're looking at falls outside of that gray bar, which is the confidence interval for the intent to treat, then you may have a problem or a signal or something.
That requires testing later.
Correct. That
Yes.
informs another study.
love it.
Exactly. But if it falls within that gray zone, if it falls within that
Yeah,
confidence interval of the.
We listened to you,
intent
man.
Yeah.
Yes.
Man.
treat. I
swear.
learned.
All right, let's
No,
listen
it's
to
all-
Dave
it's all-
O'Malley.
Yeah, that's great. Well, thank you so much. What a great conversation,
much
guys.
fun.
Thanks yeah, absolutely. It is great. So it's my pleasure to welcome up Dr. David O'Malley, who's going to talk to us about ovarian cancer now. We'll switch gears into ovarian cancer and talk about platinum sensitive recurrent and the current landscape and the updates. Dave, take it over.
Well, I have the two best jobs in the world, which is leading the division of the gynecological oncology division at Ohio State with the most amazing partners, and leading the ovarian cancer portfolio here for GOG Partners. And never had more fun in my life professionally. I didn't mean it that way, but
Of
I was
course not.
at Fowler's retirement party, and I said the best decision I ever made in my life was to come to Ohio State. And oh, my wife, boy, oh boy, oh boy, let me tell you, that was so professionally. This is most fun. All right, my family and my family is the absolute most fun I have. So we're going to go over some background. We're going to look at first line platinum sensitive. Katie Moore is going to talk about platinum resistant. We had to break it up and really talk about some of this data. And I put up some questions here at the end that are really going to, I hope, foster some of the questions. This is, we've modified this from Rob Coleman, and this really speaks to the strides that we've made in the treatment of ovarian cancer. The incidence is decreasing, and so is the mortality, but the prevalence is going up. That doesn't make any sense, right? We don't have as many people. The people are living longer. Because they're living longer, we have a lot more patients. And we see that in our chemo infusion centers, right? I'm having trouble getting people scheduled at times, okay? 39% increase in prevalence, pretty amazing. And it's because of the work, people on this call, on this video, in this room, and enroll into clinical trials. So saying that, we've had more approvals in the last 6+ years than the previous 60 years combined in ovarian cancer. 6 years in the previous 60 years combined. But what my boss in GOG Partners is Brad Monk. And so Brad goes, "What have you done for me lately, O'Malley?" And I said, "Well, I got 6 approvals." Right? And he says, "How many did you get in 2021?
Slow-mo's gotten one.
Yeah, I know. You remind me all the time. But look at it here, it's changing the landscape. How has that landscape changed? Well, now we have choices. So the first choice, neoadjuvant, we all know, right? And then surgery. After that, carboplatin, paclitaxel now is really the standard care, though I have to admit, I still talk to patients about intraperitoneal. All right, so we come up and we look at it and say, are you gonna give Bev or not? If you're not gonna give Bev, which phase 3 trials should you base your results on? You could ignore them. I tend to follow them. So if you're not going to give Bev and you have Solo and Prima and you show clearly it's PARP, there's really no debate, right? I would argue you're not adhering to the standards of care if you don't offer your patient PARP who's BRCA positive and strongly encourage, okay? I know that's controversial. The second controversial thing I've said, I don't believe that's controversial. HRD, again, talk about them, PARP, and looking at this. HR proficient, biomarker negative. Should you add PARP or continue observation? Phase 3, randomized controlled, placebo-controlled trial would say you should. And when we look at the median progression-free survivals, we have to admit these are fairly modest. In the medians, very tough to compare medians in this population because you just have so many people drop off early on. Now, if you have BED, then you have your Apollo regimen versus not continuing our population of PARP inhibitors, or do you do switch maintenance? Really, we don't have data on the switch maintenance, so really it follows in the Apollo 1, adding olaparib in those who are HRD positive. If you're proficient, then pretty clearly continue Bev in this population of patients. And why is that? And how is that going to change? How is that going to change? We have here the slide on twist, and I'm gonna come back to this, but when we look at the Prima data here that's presented at ESMO, okay, and we're looking at the quality of life, what we start to see here, if we keep the cancer away, patients feel better, okay, and that's really what the twist shows us. As you look here in the areas under the curve on the upper left, you see that the symptoms, and I know this is a busy slide, and I apologize, but the symptoms really seem to decrease in the first few months from the treatment, the toxicity, I should say. But as we continue to move forward, again, if we keep the cancer away, people feel better. And I think that's very important. This analysis really is further showing us that maintenance therapy and maintenance strategies are important. This is a trial or a report here that Dana Chase presented at ESGO, and I don't think we've talked about it enough. And this is taking the pooled analysis from the entire Prima study. And you see here in the horizontal line, identifying the quality of life scores immediately prior to the diagnosis of recurrence. And what do we see? If your cancer comes back, you feel worse. Once again, this pointing to the importance of that, the impact that the cancer has on patients' quality of life. Once again, supporting keeping the cancer away with a maintenance-like strategies. But is more better, right? Is more better. You know, if 15 months of Bev is good, how about 30 months? Well, sometimes more is not better. And we see here in the BOOST trial presented at ASCO, that is wildly negative. Each group that you looked at, subgroup, pre-planned, unplanned analyses, shows that there is no benefit of continuing the Bev beyond the 12 months. Okay, so wildly negative. We're maybe surprising, maybe not. So where does that put us? That puts us here at negative trials on immune therapy. Unfortunately, Javelin 100, Imagine 50, but 4 completed trials and 1 ongoing trial. We're honored to have Dr. Angelos Alvarez Secord, the PI of that study, here today, 405 or GOG 3035. The only upfront trial enrolling currently in the GOG with regards to it. Please consider this trial. We'll look forward to read out of the other ongoing, or completed, I should say, phase 3 trials, which we're really going to impact multimodality therapy. Getting down to some of the questions we were talking about earlier, throwing multiple agents at patients, trying to improve outcomes and maybe curing more people. Let's switch gears a little now and go into the next aspect of our highlight reel in platinum sensitive disease. As we look at this and we look at the OREO trial, which was PARP after PARP, trying to answer the question, can we treat in patients who have now responded again to platinum and have previously shown benefit from PARP therapy? So previously shown benefit in PARP therapy, they now have a response to platinum therapy, and they're randomized to olaparib versus placebo. And you see here that you have a statistically significant improvement in these arms, but we could argue what the clinical significance is here. And you see that the curves and the outcomes and the hazard ratios of very impressive, less than 0.6, that it may be being driven by a small subset of patients. So though this is a positive trial, my excitement is not as strong. I do think there for unique patients that PARP after PARP should be considered, and this trial would justify that, but we need to better identify who those patients are. How about combining PARP in patients who have previously had benefit? And in this instance, wonderful work by Dr. Withington and Simpkins presented also at ASCO this past year, combining the ATR inhibitor ceralasertib. I can't, I just had to give something Monk to make fun of me. So the ATR inhibitor, ceralasertib, okay, shows that it was actually pretty impressive. Whenever you see a waterfall plot that all of them are going down, that catches my attention. Very small numbers here. Response rate hitting at 46%. These are patients that previously had responded to a PARP and then progressed on a PARP, okay? So what we showed here is that we had a 46% response rate and a very small number of patients, but very exciting option moving forward. Well, how about other molecular changes which would predict response? Well, we saw in the report of Ariel 3 presented by Dr. Kwan at ASCO that clearly patients with BRCA predicted exceptional benefit. What do I mean by exceptional benefit? 2 years of therapy. Okay, 2 years of therapy versus the short-term subgroup, which is progression within 6 months. Okay, actually within the first disease assessment. And not only do we see BRCA mutations, we now see RAD51C or D mutations showing an increase in response, but some other homologous recombination genes did not. LOH high did predict, LOH low did not. And BRCA methylation did not seem to, but we saw patients in both. Once again, getting back to not only BRCA, but RAD51-CRD. And how about GYN-004? Joyce Liu originally presented the primary outcome last year, and Liz Swisher this year at ESMO 2021 looked at other HR mutations and how that impacted the outcome of 004. Remembering this was olaparib versus cediranib, olaparib versus a physician choice chemo. And you see in the HR mutations, which about 90% of them were BRCA, that not surprisingly, that olaparib cediranib seemed to do a little bit better there. Interesting results. We're not sure about the overall development of cediranib, especially with the toxicity, but something that the NCI continues to pursue. So 5 ongoing phase 3 trials. One of them will hit at least one. It will change the landscape of how we treat ovarian cancer. How about maintenance therapy? If we keep the cancer away, it seems to improve the quality of life. I think maintenance therapy makes sense. But sometimes more isn't better, right? You know, so throwing, and I think that really is going to be asked in these upfront trials. And how about part resistance? Are we going to overcome that? Are we going to worry about that? Are we going to combine other agents? And we have to start thinking about what other mutations predict exceptional response to PARP inhibitors, well beyond BRCA, particularly clearly RAD51-CRD right now. And I think we need to also look at some of these more rare. Thank you very much.
Thank you, Dave. Appreciate it.
Sir Alisertib, sound it out. Sir Alisertib.
Sir Alisertib. Sir Alisertib. Sir
Love it.
Alisertib.
Yeah.
Yeah, the HER inhibitor.
Yeah, exactly. So I just wanted to remind the audience to go ahead and continue to send in your questions, as they've been great and they provide a lot of good points of reference for our discussion today. So Dave, thanks so much. That was a great overview. A lot of stuff to cover in ovarian cancer for sure. We had to even split this into two, and we'll have Dr. Katie Moore speak in a second. But I wanted to ask you a couple questions. You made reference to the algorithm of frontline management, your considerations. And you said, if you use this, then, if you use Bev, if you don't use Bev. I think our audiences would be interested to know what maybe, and I'll ask you guys as well, what is the discrimination between using Bev? I mean, who do you use them in? That particular, because that seems to be a critical early, I mean, for instance, in a neoadjuvant patient, do you not use it in those patients, or do you? Yeah.
I'll start because I think there's, and I actually want to include this data, and I forgot it was from last year. Eric Pujaj-Lorraine presented the Paolo data looking at this low risk, high risk.
Mm-hmm.
Katie Moore taught me years ago.
No low risk.
There is no low risk advanced ovarian cancer. How can we talk about low risk advanced ovarian cancer? It's the most ridiculous thing. I'm sorry. And you know what? The data in Paolo shows that, right? So you're going to take the patients the best chance of cure, and you're going to deny them the best therapy. That makes zero sense to me. I give more Bev now in the upfront setting than I ever have. And I really believe the data with regards to HRD positive patients. And the HRP, the decision's then made for me on the HRP. So except for those patients who have a contraindication of Bev, I'm giving it to most patients.
You guys same? Tom, what's your thoughts?
Yeah, I'm probably a little more contemplative than Dave.
Oh,
but,
okay. All right.
but a little less pragmatic, maybe. But yeah, my Bev use has gone up, I'd say. I would say I did look at those, and I still believe Bev's wonderful for those with ascites and pleural effusions, and so I use it there, obviously. But that data has really made me pause and think about the so-called lower risk group, because there is no low risk, but there is a lower risk group, and that is true because they do better prognostically, correct. So I think harder about giving Bev, and I give more Bev. So I probably over half my patients receive Bev, whereas it used to be probably 35–40%.
And then you do HRD testing and then do Pella-1.
I actually do less Bev than I used to. I do a lot more PARP than I used to.
Yeah. So that's interesting. So tell us
and one of the reasons I'm doing less bevacizumab right now, well, obviously I think we all have a passion toward clinical trials, and FLAURA5 or GOG 3035 is open right now. And in the phase 2 randomized trial for that study, the median PFS was about 40 months for the orgovimab arm versus 12 months for the placebo group. or the, I guess, non-orgovimab group. And then the overall survival had not been reached yet for orgovimab, and it was 40 months for the control arm. So that study does not allow prior bevacizumab. So that's, for my patients that I really would like to be able to offer that study, and especially those patients who do not have a BRCA 1 or 2 mutation. So that's one of the reasons why I'm not using as much.
Who's
So
the PI on that study?
What?
Who's the PI on that study?
Yeah, right. Exactly. So, yeah,
I did the same thing. and
So,
I'm
but let me press you. Let me press you.
Randall's doing the same thing.
But
she
I'm
did.
not the PI. Yeah.
Go ahead.
Yeah, let me press you a little on that, because orgovimab is not new. So, and we've studied this. We had 3 in a row trials that were negative, right?
That's right.
But why do we believe it now?
So I think you may have been on the ad boards for those trials before.
No, I want you to explain to our
And
listeners.
yeah, I will. And during those meetings, some bad advice was given to the company about using it in the maintenance setting.
Right.
And the way this drug works
Yes.
is it enhances presentation. If it's a enhances presentation of CA-125 to the dendritic cell, so it immunizes, like an indirect immunization for the immune system. And I don't think we fully understood how that drug worked before. And so patients have to have an elevated CA-125 to be able to go on this study.
I love it. This is, I love it. I love the fact that we go back and look at the science, figure out what we did wrong, maybe made false assumptions, and then retooled it to answer a question. So it's one of the reasons that it was a prompt, because I was hoping that you would address that. Because there are people out there who say, listen, what? I remember this
You're
drug.
prompting me then, not pressing.
Well, remember,
I'm not picking on you. Like he would pick. on you. I'm just prompting
Olaparib
you.
was abandoned, right? Because
Yes,
we didn't think
that's
it
right.
worked. And now
Mhm.
it's approved in 4 tumor types with 7 indications.
Yeah, exactly. So let me ask this esteemed group also the other question that I hear a lot about with PALA-1, right? So we have this combination of drugs that have shown clear benefit in an intent to treat population, and as you mentioned, Dave, we're falling under regulatory separation, the HRD group, but we hear people say, hey, listen, I'm not going to use that regimen because I'd rather just sequence it. We talked a little bit about this in cervix cancer as well. How do you answer that? Let me start with you. In other words, I'm going to save my insert drug till later.
Yeah, well, let's talk about Bev, right?
Okay, so
Randomized prospective trials that shows that you can use Bev after Bev, and that you continue to see clinical benefit. For that answer, it's easy. Again, the same thing applies in cervix cancer. And Katie Moore's wonderful data from Solo 1 showed that we may be cured in 48% of patients with advanced ovarian cancer, utilizing PARP inhibitors in the upfront setting. To deny curative therapy, potentially curable therapy to your patients is not acceptable. I was going to say a different word, but not acceptable.
I think
Katie, what do you think?
also, yeah, I think there's a couple points. We have quite a bit of data on PARP now, and PARP and Bev, we talk about them interchangeably as maintenance, but they're entirely different mechanisms, as we all know. And Bev after Bev works, but PARP decreases in efficacy with every line of therapy that you use it. It still works in 3rd and 4th line, but it works best the earlier you use it. And the mechanisms of resistance to platinum and PARP are not entirely the same, but they overlap substantially. So when you wait, I don't understand the rationale for waiting to use PARP at all. I don't understand it. It makes absolutely no sense. I'll just say that publicly. It makes 0 sense to wait until someone's platinum sensitive and you can use it again. No, it makes absolutely no sense to do that. You're using it at a loss.
Yeah.
So you use it up
Exactly.
front. It needs to be used up front. And I think we're getting smarter about this HRP group, which I admit is our highest unmet need. It's a very heterogeneous population. PRIMA really, I think, is a great study for a number of reasons. It brought niraparib to market in all comers, but it also, I think, taught us about the importance of the clinical biomarker of response to platinum, which we knew in the platinum sensitive setting. It's
Correct.
obvious. That's why the biomarker is not essential there.
Mhm.
And in the front line, we've always said, well, we don't have the biomarker. Yes, you do. You know when someone's responding to platinum. You get your whatever test you send back and they're homologous recombination proficient. And I was like, oh, I'm so sad about that. But she's responding so well. Okay, well, I don't care what the assay says. I'm going to use a PARP, which is why PALA-1 is infuriating that I can't use
Right.
both of them in that setting
Yes.
because I know that patient's going to benefit,
Right.
as opposed to the patient who isn't responding tremendously well, and I'm going to use Bev there.
Mhm.
So, I think that use it up front and you pay attention to the molecular biomarkers and the clinical biomarkers and individualize your patients, you're going to go far.
Okay, Tommy?
Yeah, to Dr. Moore's point, I want people to think about the control arm Solo One.
Right.
Almost 20% of those patients recurred as platinum resistant.
Yeah.
Yeah.
Think of the
within 6
options
months.
they have.
Absolutely.
Think of their options.
Yeah. And remember, these are all BRCA.
These are
patients
all
with BRCA
BRCA
tumors. Yeah.
mutated, virtually all germline.
Yeah.
Symptomatic.
So Bob and Ramesh, we talked about Bev after Bev, and then we heard data about PARP after PARP. I think the Bev after Bev data that published in Lancet Oncology earlier this year is pretty conclusive.
Mhm.
Did Areo, is it also conclusive? Does it show that PARP works after PARP? Is that, tell us how you interpret that Areo study? Either
This
one
is
of
why I love the GOG highlight reel. So I think that the data is interesting. It's information. It's inconclusive in my mind. I don't think we've categorized those patients the way they need to
Yeah.
be categorized to better understand the relevance of PARP post-PARP. I will use this to make a quick plug. And that's when I was a fellow, we talked about reversal of platinum resistance.
Yeah.
And that was it. And we didn't go anywhere. Dave said for 60 years, we didn't get anything approved in the last 6.
Yeah.
And now suddenly we're fixated on the reversal of PARP resistance.
Yeah.
And I think we should just be thoughtful about, well, what's the next? We need to keep developing and advancing the science.
New medication.
Yeah.
So we get new medications and new drugs to identify what the next Dr. Secord studied.
Yeah.
What is the next drug that we're going to use to identify effective strategies? I just don't want us to get stuck in this PARP post-PARP issue and halt our progress.
Go ahead, Bob. Now I want to
Yeah.
Yeah, so I mean, I think it goes to Katie's point where she said you got to use the PARP up front, right? The study is positive, but the benefit is not great, right? If you use it third or fourth line, which is what the majority of those patients were. So I think you really just, it doesn't answer what about, in the first platinum sensitive recurrence. It doesn't answer that. And that's the key question here, right?
That's what we want.
Because now all our patients are getting it frontline.
Yeah.
Well, I hope they keep those samples though, because there are some patients who benefited.
Yes.
And if they could do some translational research on those samples and better identify those individuals, it'd be fantastic. Because it appeared from the curves, those curves for Rayo, they just dropped off. It was like a
Immediately.
cliff,
Yes.
And then the one,
4 months.
the olaparib arm, you see this benefit. It's a small benefit, but it's
Uh-huh.
about 10, maybe 20% of patients.
But I was going to
Love
ask,
it.
I mean, looks to be a difference between the BRCA mutated tumors and the non-BRCA
Yeah,
mutated
right.
tumors or
Yeah.
BRCA non-mutated tumors. So why is that? The
Because
case?
it's the clinical biomarker. that
Clinical
Katie was
biomarker.
saying.
It doesn't matter in
Exactly.
50% of those women. I mean, these women are remarkable on Areo.
Yeah.
Let's just be honest.
Right.
They're remarkable for being on a trial and all the reasons they're remarkable. But 50% of them were fourth line or beyond.
Right.
Still platinum sensitive, got a PARP. Most of them progressed on a PARP, and then they responded to the platinum, which is another big concern we don't have time to talk about,
Yeah.
is the effect on subsequent platinum. They responded again. And then the BRCA doesn't matter at that point. It's
We
the
can
response to
In a
platinum.
minute, Tom. So should we be checking for reversion mutations of BRCA with liquid biopsies before we do PARP? after
I
PARP?
say, should we? I
Yes.
would love to be able
Should
to. Yes. If we
I
could do it
think we should.
reliably, yes.
Needs
Go
to be
ahead, Tom.
commercially available.
Well, not to pile on, but I think it really highlights the importance of understanding the importance of moving PARP to frontline because of that hazard ratio. So the hazard ratio was essentially the same in
Right.
Areo
Right.
as what we saw in the frontline maintenance trials.
Yeah.
What did it purchase you? A couple of months.
Right.
It's solo
In
one,
that time.
solo two. It's
Yeah.
exactly the same.
Yeah.
Same
0.30.
Yeah. Yeah.
60% of a big number is a lot bigger number.
Excellent. Yeah. So we got about 40 seconds. Dave, you wanted to say something?
Yeah, we only have one upfront ovarian cancer trial right now. That
Yes.
we've talked about. We continue to develop more. We're going to hear a lot more in the next 12 months with regards to more upfront trials. We have 0 platinum sensitive
Mm-hmm.
at the current time. I promise you, in the next 3 to 12 months, we are going to have options in platinum sensitive. I've gotten all your emails. I know we don't have everything in platinum sensitive.
Yeah.
The
I
next
know
highlight
that.
reel.
Okay. Yeah, exactly.
Highlight.
Next highlight reel,
Yep.
we're gonna be able to talk about some.
Yeah, we,
So
love
thank
it.
you for everybody who participated in the clinical trials. We need to continue to do better.
That's awesome.
Even
Thank you so
balance.
much. Yeah, I think you said it very well, David. We really do need to not only get industry to help us get those trials done, but we need you to help enroll to them. So now to bring another difficult area to talk through is platinum-resistant ovarian cancer. And Katie Moore is going to walk us through the innovation that's happened in this space.
Yeah, thank you. So it's my great pleasure. I think I'm the last presenter of this first inaugural GOG highlight reel. So it's my great pleasure to sort of round us out with updates on platinum-resistant ovarian cancer. I'm going to throw in a little low grade just because I wanted to. And this is really how to organize it. So there's a lot of data in development in platinum-resistant ovarian cancer. So I'm going to take you through sort of the categories where development's going on and then give you an example of some results from the 2021 meetings in each of these categories. But just to say that there's quite a bit that's in process in the platinum-resistant ovarian cancer space. And so we'll kind of march through this. So these are even not exhaustive, but within the GOG and NRG, these are the open or opening trials in the platinum-resistant ovarian space, and kind of roughly categorized as agents that synergize well with taxanes, antibody drug conjugates, novel immune combinations or immune therapies, and then strategies that target replication stress, really speaking in particular to this post-PARP space. So let's start with the taxanes. I'm just going to take us through briefly the studies that are open and accruing so you can understand where the science currently exists. So we'll start with GOG 3018. This is the OVAL study using VBL111 with paclitaxel versus paclitaxel alone in a platinum-resistant ovarian population with 1 to 5 priors. This has been open for a while. We're closing in, guys. So if you have this open, we're expecting it to round out in first quarter. So please focus on this study and getting it across the finish line. For those of you that don't have it open, just to remind you, VBL111 is super interesting. It's a very novel asset, kind of dual mechanism of action. It's a gene therapy that targets tumor vasculature and leads to tumor starvation. And in addition, it has this adjuvant effect that's an immune effect, which triggers an immune response and infiltration of cytotoxic CD8 T cells into the tumor. So you're kind of coming at it from an immunotherapy and an anti-angiogenic strategy. So a very novel, cool agent, closing in on this. So please help us get it over the finish line. GOG 3029 is over the finish line. So congratulations to all of you who participated in Innovate 3. Now it's just has to mature and let us know its results. For those of you that were not involved in Innovate 3, this looks at tumor treatment fields completely different. It's almost like a device rather than a drug. I guess it is a device where patients will wear this kind of device around their abdomen that has tumor treatment fields. And what tumor treatment fields do is it disrupts localization of molecules that have a polar end, like microtubules. And so it disrupts the mitotic spindle and leads to cell death via that mechanism. And so obviously, if you're disrupting the mitotic spindle, sorry, lost my words, that's going to be synergistic with taxanes, which is why here it was combined with weekly paclitaxel. So again, Dave O'Malley led this on behalf of the GOG, completed accrual, and now we're just waiting for the results. So we may hear about this next year, maybe. 2 that are active and accruing that you should know about. GOG 3044 is led by Dr. Tom Herzog. This is the Profecta study, which is looking at a novel AKT inhibitor with paclitaxel versus paclitaxel alone. I think we all know the rationale for AKT, but this PIK3 AKT pathway is upregulated in about 40 to 45% of tumors, epithelial ovarian cancer tumors. So a lot of rationale for targeting this. A little bit of a different inclusion. It does have pre-selection by tumor testing and is only 1 to 3 priors. But this is open and accruing. So if you have this open, thank you. And then finally, GOG 3059 is the AeroVive study. This is using, again, this is a really cool group because it's it's actually all assets that we really haven't used before. So, something different than PARP and bevacizumab. So ABB 500 is a novel ligand that targets the AXL Gas6 pathway. So AXL, you probably haven't heard a lot about unless you have the study open, but it is a transmembrane protein that signals a whole bunch of bad things that tumors do, inclusive of inducing tumor growth and metastasis. Dr. Catherine Fu is leading this. This is based on a decade of her work showing that upregulation of the AXL pathway is correlated with poor prognosis in ovarian cancer, and preclinical work that shows that when you inhibit AXL, and you can't inhibit the receptor, but you can suck up its only known ligand, which is called Gas6, that you can downregulate its activity. And when you downregulate it, you actually lead to accumulation of paclitaxel in the cell, hence the combination with weekly paclitaxel. So this is weekly pac with or without ABB 500, a drug with really no toxicity. So this is the Accelerate trial. We are still doing a little bit of site selection for this and in ramp up phase. So thank you for those of you who have this open and accruing. We're doing great, 1 to 4 priors, and no pre-tumor testing is needed. So that is sort of our current palette for the weekly paclitaxel category. This year, in terms of things that fit into that category, we had relacorilant and Abraxane. And so this is a really interesting drug. Relacorilant is a glucocorticoid receptor modulator, and there's quite a bit of preclinical data in a number of tumor models, in particular with Abraxane, that you can reverse chemoresistance with this agent. And it's been studied in a few different studies. This one was presented this year. It's a randomized phase 2 in a platinum-resistant ovarian cancer population, and randomized women to Abraxane alone, which I acknowledge is not quite the standard comparator, but it's something we use, versus 2 different ways of administering the relacorilant. One is continuous dosing and one is intermittent dosing. So intermittent's in green, continuous is in blue, and then the gray you can see the comparator arm. Again, a randomized phase 2, but you can see the PFS curves here with a signal of superiority of the intermittent dosing. Certainly both relacorilant arms look better than Abraxane alone. The intermittent arm statistically was the superior arm here. And here is the swim lane plot, so you can kind of see the duration of response in each arm, as well as the overall response rates, again, with the intermittent dosing having a higher, about the same response rate, but a significantly improved duration of response on the median here. So this is an interesting agent, and I think we'll see trials coming out of this randomized phase 2, so pay attention to this moving forward. So next category is antibody-drug conjugates, which for those of you that know me, know I love PARP inhibitors and antibody-drug conjugates. This is Mirasol and Mersana. So Mirasol is our randomized phase 3 of mirvetuximab versus investigator's choice chemotherapy in folate receptor alpha high tumors. And GOG 3048 is the Mersana Uplift study, which is the mainly phase 2 of upafitamab in 1 to 3 priors. We have data on mirvetuximab and bevacizumab that Dave O'Malley presented this year at ASCO. This was a platinum sensitivity agnostic study, so you could be either platinum resistant or platinum sensitive. You just had to have high folate receptor alpha expression, and patients were treated with bevacizumab and mirvetuximab. And you can see the response rates are huge, 59% and 69% in the resistant and sensitive population, respectively. So very nice signal here. So once we push single agent mirvetuximab over the finish line, we'll have a nice opportunity to expand the indication. This is upafitamab presented at ASCO this year. This is the single arm study with a very nice response rate. 67% of patients had a reduction in tumor target lesions, and the response rate is sitting right about 37% at this point. This is moving into, I know Dave promised you I got permission to show this. This is the platinum sensitive study that is coming. It's not quite before the FDA yet, but we have permission to tell you it's coming in first quarter, incorporating upafitamab as maintenance therapy in a platinum sensitive population. So keep your eyes peeled for this. For immunotherapy, currently open, actually GY009 is open, but completed accrual in the NRG. So congratulations there. but we have the artistry study open. So this is open and site selecting. So for those of you that are interested, please reach out here. This is nemvaleukin and pembrolizumab, really versus investigator's choice chemotherapy, but there's 2 small arms to sort out the relative contribution. Nemvaleukin is an interleukin 2 receptor modulator. So it's going to upregulate your cytotoxic CD8 T cells, natural killer cells, and it doesn't expand the T regulatory cells. So it's a very interesting mechanism of action. This is open, just starting to accrue, and we are still site selecting. Immunotherapy has been a little disappointing, but I am showing you the data that's been presented this year. This is OPAL, presented by Joyce Liu at SGO, which is niraparib, dostarlimab, and bevacizumab with a response rate of 18%, modest, but not overwhelming. And then we saw at ASCO pembrolizumab, pegylated liposomal doxorubicin, and bevacizumab presented with a response rate of 32%. So that's a little bit more interesting and gives me a little bit of optimism about NRG-GY009, but we'll see that study is maturing. And then our final group is targeting replication stress and PARP resistance, where we have 2 studies upcoming in the NRG, both led by Panos Konstantinopoulos. GOG-GY029 is investigator's choice chemo versus olaparib and copanlisib. And then NRG-GY030 is gemcitabine versus gemcitabine ATR inhibitor. And you heard about ATR inhibitors already from Dr. O'Malley. Targeting replication stress, we heard from Shannon Weston this year with WEE1 and olaparib, so adavosertib and olaparib, and BRCA wild type and mutated cancers who are PARP resistant. Here's the BRCA mutated response rates of 20 and 20%, so okay. But in the wild type group, we saw 31 and 40% response rates with incredible duration of response of 8 months. And so this is a very interesting combination that needs some further finesse from a toxicity standpoint, but we're very proud of Dr. Weston's work here and look forward to seeing what happens next. And then you heard already the Capri study that's platinum sensitive, but targeting replication stress. So I included it here as well with a 46% response rate and 7.5-month PFS in a PARP resistant population. So a nice signal. We just have to figure out what to do kind of with these agents moving forward. Low grade, just to show you the last 2, I forgot to put these in. This is the Milo update of MEK inhibitor versus investigator's choice chemo and recurrent low grade. And unfortunately that even though it looked a little bit better, it was statistically not superior in the Milo study. However, in the subset analysis by KRAS mutation, you can actually see quite a big signal for MEK inhibition that really prompts us to take another look at this population. So this is the biomarker data, really, I think, driving home the benefit of MEK inhibition, specifically in KRAS mutated patients. And that's being followed up now in our ongoing GOG study, which is based on this phase 1 data called the FRAME study, which is VS6776, which is a MEK RAS inhibitor plus defactinib. Here, this is low-grade ovarian cancer with response rate of 64% in KRAS mutant tumors, 44% in wild type. So the study is currently open to all comers, and it's probably the most exciting thing we've seen in a long time for low-grade. And with that, I am going to leave that up because it won't advance.
We'll
I'm
go
done.
anymore.
Thank you.
Yeah, thank you so much,
Dr.
Katie.
Moore.
Appreciate it. Yeah.
That's right.
Excellent. Another great, fantastic presentation. So again, we have this last section is here. So go ahead if you have any questions, send them through, and Dr. Monk and I will keep an eye out for them and try to get to the questions. So Katie, let me. You presented, a great portfolio of trials that we have, and I think the comment. I mean, we're all believers, right? So it's like any patient who we see in this setting should go on a trial. But what if? Which one do you put them on? I mean, how do you make a decision like that?
Right. So that's
first you got to have them open, right?
Got to have them open.
Okay.
You need more than one open.
Right.
Because the reality that we all know is that unfortunately our patients, once they have this acquired platinum resistant, they're going to need a few lines of therapy. And I didn't have enough time to go into granular details, but some of these are 1 to 3 priors, 1 to 4 priors, 1 to 5 priors. And so you can have 3 studies open and kind of line them up as opportunities for your patient. So having a nice palette open when your institution allows is key. And then also the biomarkers can direct which ones you use. So for example, and I'm the PI, so I am biased for Mirasol. I mean, I have to say that. But I screen everybody for folate receptor alpha. And if they're high, which is 40% of the population, that's going to be my first choice. And if they're not folate receptor alpha high, I have this other palette of options that I can look at, and I kind of line them up to not exclude one another by number of priors or other things.
Yeah, Dave, I know you spend a lot of time looking at portfolio management. What are your thoughts?
Well, let's just talk about what a response rate is in contemporary patients.
Yeah.
10% plus or minus about 2-3%,
Mm-hmm.
maybe 5%. Maybe you can get up to
standard therapy.
15%. For standard
Like
care in
Doxil.
platinum-resistant ovarian cancer, in the contemporary way we treat patients across the board, it's very consistent.
Mhm.
We, in the partners program, will really not seriously look at an independent drug, but standalone drug, with unless it has a response rate of 25%. You saw the work that Katie just presented,
Mhm.
25%.
Yeah.
Our contemporary is 10%, probably closer to 5 to
Mhm.
8, but we'll give it, okay? So you have the option of standard of care. You are probably giving your patients a better chance to almost double their response rate, okay? How do we sequence it? Everybody gets tested for their tumor to see if they're eligible for a biomarker positive study. That's the first thing you have to do. And you have to see right away. What else? Are they candidate for weekly paclitaxel? If they're candidate for weekly paclitaxel, you absolutely should have one weekly paclitaxel trial open, and then one antibody drug conjugate, and if it's a biomarker positive, and then a third. We should all have at least 2, if not 3, platinum-resistant ovarian cancers, because many of them now allow up to 5 prior therapies.
Mm-hmm.
And we need to educate IRBs. I get a lot of pushback. Well, no, I only have one platinum-resistant. No, you can't. Oh, slower. I'm getting all excited. You know how passionate I am about this. Am I going too fast?
I don't know.
Listen, we were concerned putting
So
you
Dave,
guys next to
that's
each other.
great. What happens, and Brian just moved to a new institution and he's gone through this.
Yeah.
Leslie's moved. How do you get your institution though engaged? You just don't snap your finger and say, open these trials, because the institution may not have the resources, they may not have the capability. How have you guys done it, Brian and Leslie, in these new institutions?
Yeah, no, thank you for that. And I love this presentation. And Katie and Dave and the whole group, you're doing phenomenal work with ovarian. And I agree with what you're saying. And to Brad's point, for an established research institution,
Right.
We are, and I'll highlight what we said. We're not an exclusive group. We're an inclusive group. A lot of the folks who are watching us now don't do they can't do as many clinical trials as Katie does in Oklahoma, or Dave does in Ohio State, or Leslie's doing, or any of the folks here. So, one of the things that I would say that's really nice about our group is let us advise you.
Right.
Shoot Katie an email saying, I haven't done a platinum resistant trial yet. Which one do you think I should open? And then open one and let us guide you through the process. And then once you have one open, then truthfully, you'll need to show that you can accrue.
Mhm.
It's not opening trials that matters, it's putting patients on trial. And then once you get one open with a couple of, then let's get another one open in platinum resistant.
Mhm.
Let's then think about a first line cervix trial. Let's get, one of the endometrial, so start slowly, but I agree with you completely. Once you're at a good pace and, you're doing well, get 3 open, because the portfolio supports it and you guys are doing a phenomenal job. But I also just want to not forget the inexperienced researchers in the room, that we're here to support you and get you that one trial open.
We pick our jobs too. So you got 2 options. One is when you get a job to try to go to Oklahoma or Ohio State, or to try to go and sort of be the trailblazer. And it's okay to be the trailblazer.
Mhm.
Someone said here, they said, I want to do more clinical trials, maybe even be a PI. How do I do that? It's actually pretty simple, right?
It is.
You enroll. And the other thing is, to your point, many of our trials are run by others than this group. Catherine Fu,
Mhm.
Debbie Richardson,
Mhm.
Richard Penson,
Mhm.
Rachel Grisham.
We're
They're not
inclusive.
here. We include everyone. And you know why they're leading our trials? Because they enroll.
Right. And to answer that question, specifically, the person's doing the right thing. The first step is to come to these meetings. We're having a ton of great webinars, the highlight reel, all of these webinars that GOG has been doing, led by Jenna Cummins and her group. They're doing a great job. The next thing is go to the meetings.
Right.
The last 2 years, we were fortunate you could do it virtually, but where you invited everyone to Phoenix Bread, go to the NRG and we have usually a GOG partners reception, and pull us aside, talk to us, email us.
Absolutely.
And then from doing that, then when you open a trial, make sure you go to the investigator meetings. These are free seminars on what to do to how to run a trial. Always be in contact with the PI or your CRO. And, and once you open one, we've all started, every single one of us is doing clinical research started with one trial. It sounds sort of
Exactly. The first step,
weird
right?
to say, but you start with one, you get it on,
One.
and there's plenty of room to have more experts in the field of clinical research.
Right.
I
Leslie?
think that's true. And I agree with almost everything that you've said,
Almost.
but I will say that I've been really lucky. And that is that, I came with experience to VCU, but my team, Steph Sullivan, Devin Miller, Sonia Washington, our nurse, I mean, they're knocking it out of the park. And we don't even have a big practice, but we do have platinum resistant patients. And I don't want to give them Doxil, and I don't want to give them cytidine. So I have to bring them treatments through trials. And we have had 3 trials open in exactly the way that Katie, presented it. And then we'll open our 4th in the last category that you presented. And we game it, just like you said, they get multiple lines of therapy. It's always a trial. And we've been able to accrue in our, our small varsity and our small varsity team, because it's a team, have been able to do it.
Yeah, I will say, you remember, Dave, at the beginning of your talk, you showed the prevalence rates going up with incidence going down. So we are seeing a lot more patients, to your point, that are in that recurrent space. And so we all feel it. We all have it in our clinics. And so there's an opportunity, and we have to, keep pushing the envelope to change it. Yeah, Dave.
I think as we look at these opportunities and we have 4 or 5 tricks up our sleeve once they become platinum resistant standard of care, right? With median progression-free survivals, we just saw about 3 months.
Yeah.
If you can get a patient onto a clinical trial or 3, you just gave them another year. And if you hit a home run on MERV for a patient for a couple of years, which we all have in our practice, or some of these other agents, you really impact their survival and opportunities. And the quality of life on many of these agents is equal to or even superior to what we have available. Standard of care.
Can I just mention one thing? I want to go back to the person who said they wanted to be involved in clinical trials, maybe in BAPI. I just want to remind everybody, and you guys have been really great and involved in this, is the GOG Foundation has led a huge commitment to learners, to the GOG New Investigator Program and the Scholar Program. And we're really hopeful to be able to open that up again this summer. So look for those RFAs and please apply, or just reach out to us, especially if you're within that 7 to 10 years after being in practice.
Yeah, so we send out a site feasibility survey, right? We say, hey, we're going to do this study. Do you want to do it? That's when you get involved. Once it's ongoing, you say, oh, I like that study. Well, the sites are already selected. But the good news is that with your leadership, the studies are coming, every few weeks. Go ahead, Tom.
Tommy?
Well, I think one of the things that people don't realize is how we say we're inclusive, et cetera, but we really walk the walk as well. And I don't think people realize, if you want to be a GOG site, let us know.
Yeah, well, exactly. It's easy.
Paperwork
becomes very easy. Yes.
We're an easy club to get into.
Right.
Yeah, I just want to come. I'm sorry. One of the barriers that people say is that research, is too expensive. My site won't support it. It has to be done at a university site. I just want to reiterate the point that you don't need to be at a university site to open these research trials, number 1. And number 2, if part of your hat is you want research, but part of your hat is to grow your practice, having research protocols at your institution that's unique in your region or your town is going to bring patients in the door. So you have to talk to your administration.
I can't separate standard of care from research. I mean, from clinical trial.
Oh,
It's the same thing.
They're married.
You should have it there. Dave?
But Brad, you just brought up a very important point.
It's rare, but go ahead.
Yeah. Exactly. I'm writing it down.
Maybe the
What was
only
this?
one I've heard you ever bring up, but be responsive.
Yeah.
Be
Responsive,
responsive.
right?
Yeah.
If you get an email from the GOG and Katie Campbell, respond to it. If you
That's
want to
great
be
point.
an investigator, and then if we send you an email and say, hey, you've been selected for feasibility, respond to it.
Yeah.
Well, and I think it's important for people to know what the typical turnaround time for a lot of sites, the really good sites. I mean, she's getting responses within 24 to 48 hours. And I think if you're not in that culture, like you may not realize that that's the norm, but that's the norm for some of our sites. They really do a great job.
And it's a passion, right? You called out your team. My CRC just put in the chat, it's our duty to offer our patients.
I love it.
I love
Terry
it. I love
Thomas.
her. Yes.
No, it's
I'm
true.
coming to her. when I
But
get
you know,
cancer.
each of you guys have developed a program within your institutions. I think people out there are asking, how do I set up a program?
Mm.
Call us.
Mhm.
We're more than happy to work with you and tell you how to staff it,
Mhm.
what and the steps to do it. I mean, it's
We also have some archival videos.
Mhm.
That's
Katie's
right.
Done, and I've done. and
Yeah.
A lot of us up on here have done with people who have had success starting a new practice, starting in some environments that would be otherwise considered very difficult and being
absolutely
successful.
fantastic.
And we like the NRG a lot, and we support the NRG, and we enroll to the NRG, but the level of reimbursement for GOG partner studies is different.
Mhm.
And so we would never expect or even think of doing a trial at a loss. So you may not make a lot of money on these trials, but at least
can cover costs.
you cover costs. So if you can cover costs, and then for all of these other opportunities for patients and for you, because it's fun,
Mhm.
it's a no-brainer.
And it's the right thing for patients.
Right.
Yes.
Yeah.
So it's been hard because there's been 8 of us to all get our perspectives, and so we've sort of reserved the last 15 minutes to sort of go around the room so that everyone feels like they contributed. I'm going to start, and then the 8 of you can make a comment, and then we'll give Rob you the last.
Oh, I get the last one. Like,
insightful
oh, I'm gonna come up with
words.
one insightful thing that somebody else didn't say.
So and Dave, you're working very hard, and I'm grateful. Okay, you're working very hard, and although you didn't get any I mean, it's only November. You might get
Matter
an
of
FDA approval in the last
Aw.
5 weeks, but
It's all his fault.
even it. I know, but you don't have to say it.
Oh, okay. I'm sorry. Oh,
So listen, what I'm excited about, we have a number of trials they're going to report. Some are GOG, some are not, in 2022.
Mhm.
That's what keeps me going.
Mhm.
To Katie Moore's point and your point, you're the PI, Soraya, mirvetuximab soravtansine is going to report any day.
Mhm.
Okay. And to Dave O'Malley, innovate, right? 3018, it's probably going to have at least some, and you may not hear, so they may do an interim analysis, but the data will be cleaned and someone will look at it. And if it's as fabulous as we hope,
Mhm.
it might be at ASCO, or I don't know, I'm not saying, okay. Oval, right? All of you many of you work on Oval. That study is nearing completion. So that's what I'm excited about, is what's next. And this has been a great year, Leslie. 2 FDA approvals in cervical cancer. It's never happened.
Mhm.
Never,
Never.
right?
Never.
And the first phase 3 second line, Brian, endometrial trial, July 21st, 775309. So that's what I'm excited about. That's what keeps me going. I'm just going to sort of go around. Maybe I'll start with you, Leslie. We'll just sort of go around, Leslie, Dave, and so on. Just get on your soapbox. And what are you excited about? What's the message to our listeners as we, like Cope says, transform the standard of care?
Thanks, Brad. Gosh, I'm excited about so much. I mean, look at the volume of what we've presented today as a group. And I'm really excited that we're reaching patients, and like Brian said, we're reaching them outside of the academic settings. We're reaching them with different approaches. Katie showed 10 different mechanisms of actions of different drugs. It's just so exciting that we've got all of these different opportunities. And then, I have to close it off with cervix and say that, I think that we'll really make an impact in the locally advanced space, and that's going to make a huge impact. And, I just want to keep bringing more trials, bringing the combinations. I think, maybe try to find ways to make 4 drugs easier on patients, making sure we're reaching all of our patients, making sure we're closing our disparity gaps and not making them worse by bringing these new therapies.
Awesome. Dave?
Thank you.
Clearly my passion. I've already been on the soapbox a couple of times.
You're still on it.
My passion, though, what is my passion? My passion is helping women with GYN cancers live longer and better.
Right.
That's
Yeah.
my passion.
Yeah.
And how do we do that? Through clinical trials. We all are working very hard. As GYN oncologists, you don't get here unless you've worked your butt off, right? Now, Are you going to impact the thousands of women that you take care of? Absolutely. And thank you for your work. And you need to continue to do that. But are you going to have an impact on the next generation when you're retired, the generations after that of women with GYN cancers? And how are we going to do that? Through clinical research. Just don't take care of the patient sitting in front of you. Take care of her loved one, her daughter. And again, get them to enroll in clinical trials. Our emails are available. We try to respond very quickly. We're here to help. Thank you for all the work you do.
Yeah, that's great. Yeah, no, we all love being here. I love doing this. I love doing the research, but we do it because we're passionate about it and we want women to live longer. One of the things that we really didn't highlight today is that this is just not a national effort of what we're leading. We have strong partners internationally. We have a strong relationship that a lot of these studies that were listed are being done between here and our European colleagues, our Asian colleagues. So our desire to treat these malignancies is just not a local or national effort. It's really worldwide. And our group is working well with these other areas in doing so. Secondly, and Leslie touched on this just now briefly, but we need to do a better job in increasing the diversity in our clinical trials. Right now, there's a completely, it's imbalanced, not favoring some of the diverse populations, and we're working actively to doing so, and we need to work harder. So I think that's one of the areas that I think we're all passionate about, and not only to be equal and balanced from a equity standpoint, but the diseases may be different in different populations of patients. So we're working on that. Third and finally, you know, I'm privileged to lead the uterine cancer portfolio. I love what we're doing now, and I'm really even more looking forward to incorporating some of these therapies into the first line setting, and then coming up with next generation trials in the second and third line. But this is great. Thank you.
Katie.
Well, I'm excited about mirvetuximab.
Mhm.
So what did you say?
No, go ahead.
Okay.
Mm.
No, I'm just kidding. Well, I'm not kidding. I'm very excited for mirvetuximab. And that's all. No, I'm just kidding. So I think that one of the most exciting aspects that we've been working on that has been alluded to is the fact that we're getting more individualized with how we take care of patients. You know, when I was a fellow, which was 2004, a long time ago now, everyone got surgery, whatever the outcome was. Everyone got surgery, everyone got Taxol carbo.
Mhm.
That was the thought process.
Exactly.
That was what I would say at boards. And it's just, and Dr. Copeland was my examiner. I think I did okay. But it's so different now. You know, there's so much individualization even in ovarian cancer, and it's getting more and more fine-tuned to really help women live better and longer lives. The same is true in endometrial cancer. We're actually putting into practice the 4 groups of the TCGA, which were just sort of a nice slide for however many years. Here are the 4 groups. Okay. Now we actually have therapies that we're marching out. We talked about another study today in copy number low of all things. So,
Mhm.
and that's coming, but I can't talk about it.
But I can't talk about it
yet, but it's coming. So, I mean, that's exciting. Replacing chemotherapy for women with advanced endometrial cancer, potentially replacing chemotherapy for cervical cancer with targeted therapies, I think is just key. So it's an exciting time to finally just not be giving Taxol carbo to everybody.
Yeah.
And
Great.
that's really testament to clinical trials and paying attention and doing the extra work to make sure the patients are getting the therapy that best suits them and not just
Great.
Taxol carbo.
Ramesh?
Yeah, first, it's always humbling to be surrounded by brilliant minds like this on the GOG highlight reel. So thank you for having me. 2 things. Number one is, as was mentioned earlier, we all started somewhere. So I want to empower everyone who's with us today. You can open trials at your institutions. You can get started. You can make a difference, and you can transform the lives of patients suffering from GYN cancers. Secondly, we're making advances with drugs and drug development. We're also opening surgical trials, which is a big, it's very important to all of us here. Those are being led by the individuals in this room. Hopefully a HIPEC trial, hopefully a cervix trial, robotic opportunities, minimally invasive surgery. So we are making progress across the board. It motivates us. It gets us up every day. And I'm thrilled to be a part of it.
Awesome.
Yeah, those are coming soon and they'll be on the
Yes, there
next
you go.
highlight reel. And now I'm busted. Kristen Bixel
Yeah, well,
and
I figured,
Mario
you know,
Mateo, whose robotic cervical cancer trial is this close to opening. And a lot of you have signed on and are really excited about that.
Absolutely.
Great, thanks. Barbara.
No,
Bhavna?
Yeah, so it's been amazing to be a part of this GOG highlight reel. I can't think of a better time to be doing trials and be a part of these amazing transformational changes that have occurred in our field. And Dave, highlighted in ovarian cancer, we've had 14 new approvals, right, in the last 6 years. I mean, in the last 3 years, we have transformed the way we treat frontline ovarian cancer. We have changed the way that we treat endometrial cancer, recurrent endometrial cancer. We have changed the way we treat cervical cancer. I mean, I think it's incredible. And all of this is through clinical trials. And, we have to thank, the sponsors for what they do to help us achieve these advances. But let's not forget about our patients who really help us in this mission. And I'm just grateful that our patients are so open to the discussion of clinical
Right.
trials and are so willing to participate to
Mm.
help us make these great advances. And as everyone said, I am happy to talk to anybody about helping set up clinical trials at their institutions. Thank
Love
you.
it. Thank you. Angeles?
Wow. Well, I think I could sum up what I'm feeling in 4 words from Brian's last slide, right? The future is bright.
Mm-hmm.
It's also incredible because there's so many different trials and so many different numbers to remember. So it used to be maybe we'd have one advance in 3 years and you could keep going on the same slide deck without a lot of modifications. Now we have all these different studies and medium PFS, medium OS to remember, response rate. So I think the GOG highlight reel is a great opportunity for us to be able to review that data and then come together and talk about it and synthesize it and determine how we're going to treat our patients in clinic. I echo all the eloquent words that have already been stated. It's a pleasure to be here. And if anybody's interested in terms of being a new clinical trialist and wanting to get on board and learning how to do this from the ground up, let us know. There's programs through GOG, through Energy, and even SGO. We are very engaged in wanting to help people move into this space.
And Angeles, I want to thank you because I'm a product of those sorts of junior investigator grants.
Mm-hmm.
So
Yeah.
early on, I
Mhm.
wanted to be part of this and I filled it out and I got rejected. So I did it
Yeah.
again.
Yeah,
So
absolutely.
I
the passion. Yeah,
So-
absolutely.
Rejected
So that's
again.
one of the most important things. I mean,
I didn't get rejected, got a K award
But
actually.
can I just
Yeah,
say,
ultimately,
can
got
I
there.
just
Yeah,
say
but
with
it's persistence.
clinical trials and therapeutics or any aspect of medicine or life, for instance,
Right.
so this is
Yeah.
really important. Resilience
Yes.
and grit, and just do it again and again and again until you succeed. That's
How
the
would
best.
you find out about those mentorship opportunities, whether it's the SGO or GOG? How do they find out about them?
So the GOG Foundation communication team actually does a great job in getting out that message. So there'll be an alert when the next call goes out
Okay.
for GOG new investigators as well as GOG scholars. So we're hoping to open that up later or next year.
Okay.
And then through Energy, there's an early career new investigator committee, and that announcement will go out. If you miss the announcement, just you can reach out to us. I can see how I can help you. And then SGO has a early emerging clinical trialist course.
There you go.
Yes, and I
Mhm.
think that's been fabulous. They've run it. It's been several years now. They did last year's virtually. I know, Rems, you've been involved in that programming, and we're really hopeful that we can expand that into an even larger partnership because we're all part of this great collaborative team.
Mhm. And you're very approachable, so I
Yeah.
appreciate that.
Yeah. Thank you. Tommy?
Yeah, is this live?
Yeah.
I was kind of hoping that we could just stop and I could go first.
Yeah, exactly.
That's what I'm saying. It was so well said by all of you. It really was. The only thing I will say is that, we're coming upon the week of Thanksgiving, and you heard it several times. There were several words I thought that resonated as a thread throughout the highlight reel. And one was gratitude and gratefulness. And I'm so grateful for this opportunity to be with all of you. I'm grateful for the great GOG partners leadership team, our events and programming team. What a great group to work with. So I'm really grateful on that regard. Also very grateful for all of you for joining us, because to give up a Friday afternoon means a lot, and it shows great interest. And we are, I stated it earlier, but we're open. We're totally inclusive, and we want you to join us. The application is very simple, and we want to help you become a trialist. And you can call me or email me at any time, and I'm happy to talk as well. I've seen a lot of lessons from community all the way through difficult university systems. So happy to give advice. The other thing I'm grateful for is I don't have to take boards and memorize all these new things.
Well, you got Dave to help you pronounce it.
Yeah, so that's good. And the last thing I'll say, and the other word that I heard was transformative.
Yeah.
And I think I heard it a couple times as we went around here, but I also heard it during the presentations. I think I heard it at least 5 or 6 times today. And we really have transformed the treatment, frontline treatment of ovary, cervix, endometrials, right there. Everything is changing so rapidly, all at the same time. That's why we need you, because we have more drugs and more opportunities than we've ever had. And we can accelerate the progress that we make in women's cancer by having more of you open sites and become trialists. So we really need you. You saw the portfolio, for example, with platinum-resistant ovarian cancer. We really need more trialists. The last thing I'll say is that goes with transformation is that if we think about, I'm one of the oldest people here, and I will say that the trials used to be very incremental, if you remember. Can we switch out a platinum to a different platinum?
Yeah.
Let's look at that with almost 1,000 patients.
Or just
Let's
put it
do
in the
that.
belly.
Yeah, or let's do that. Let's give the same drug by a different route, or let's give it a different schedule, all the dose dense things
Yeah.
we've done.
Oh, yeah.
We've gone from incremental to innovation.
Yeah.
And our trials now are so innovative with unique mechanisms of action and with really the ability to change the field. And I think that that's something that heretofore we haven't seen in gynecologic malignancies.
Yeah, agreed. Yeah.
I'm grateful for the amazing work by Dr. Tom Herzog and Dr. Katie Moore in the
For the
Investigators Council,
Yes.
and engage a different level of engagement with our investigators,
Yeah, right.
and really taking and establishing the next generation of leadership within GOG partners. Thank you for all of your work.
Yes.
Thank you.
Yeah, I guess my for people who've heard me give this lecture, this type of lecturing before, I always end or have started a deck with research cures cancer. I think you've heard it all here. That's how we move the field. I feel, right now we're all believers, and we're trying to get you to be believers with us as a way to really transform, to take that term, Tom, transform the standard of care. It's our obligation, I feel. I mean, that's why
Some of them are believers already.
yeah, I
so-
know. But I really feel like it's our obligation, and we can't be, satisfied with the status quo, and we got to keep pushing. So, part of what I see as the reason we've made more transformative moves and advances is that we've taken risk, we've done a better job with our science, and we've enrolled and learned. And so I'm incredibly grateful for that, and to all of you. I also want to do a shout out to our president. And I don't mean Biden. I mean Dr. Copeland. Who through really incredible vision, I think, in support and allow this to happen to all of you and all of you out there to happen. So Cope, we're really appreciative of what you've done, and provide us an environment that we can take those risks. And that's really important. So I'm excited, hopeful, excited, and can't wait to see what it brings.
And last but not least, Jenna Cummins,
Yes.
Lindsay Muller, and Linda Gildersleeve. So
Yeah.
let's give them a hand. And more to come. So this is the first in a series. I anticipate that our next one will be after the SGO to highlight the SGO.
Absolutely.
So thank you. Thank you for the audience. Thank you for our sponsors, very much so. And thank you for our panelists. So long for
Absolutely.
now.
Take care.